Assalamualaikum and a very good morning to everyone. Thank you all for finding time to join today's day 2 of the webinar on strengthening prevention of mother-to-child transmission, PMTCT, of HIV and syphilis program in Malaysia. Updates on PMTCT guidelines. which is organized by the HIV, STI, and Hepatitis C sector of the Disease Control Division, Ministry of Health. My name is Dr. Muhammad Izzat Anwari, and I am the Principal Assistant Director at the Disease Control Division, Ministry of Health. I will be the moderator for today's day 2 of the webinar, which will be the last day. First and foremost, we would like to thank the National Institute of Health, NIH, for co-organizing today's webinar. Just a little housekeeping before we get started. Please register your attendance at the link at the YouTube description below or at the link in the Webex chat box. And if you have any questions during the presentation, refer to the YouTube description as well. Just click the relevant link if you want to ask any questions. We will try to answer the questions during the Q&A session. If time doesn't permit, we will try answering through your email. Now, I will talk briefly on the objective of our webinar and the agenda for today. Okay, we are having the webinar on strengthening prevention of mother-to-child transmission, PMTCT of HIV and syphilis program in Malaysia. Updates on PMTCT guidelines. Just a brief background. The DG of Health has recently endorsed the second edition of the Strengthening Prevention of Mother-to-Child Transmission, PMTCT of HIV and syphilis program in Malaysia guideline on the 28th of June 2021, just recently. This is to ensure that Malaysia still retains its achievement of the first country in the World Health Organization, Western Pacific region to be certified as having eliminated mother-to-child transmission of HIV and syphilis. The webinar objective is to update and enhance all health practitioners on the current knowledge and management from the new guideline, and to highlight issues or shortfalls of current management of PMTCT program in the Malaysian setting. So what we had yesterday, on the 27th of September, we had one keynote speech by Dr. Anita and 3 topics given by 3 distinguished guests and specialists in their own field. And you can watch again the YouTube link, the video yesterday by clicking on this link or searching on your website this link, bit.ly stroke PMTCT day 1 for yesterday's video. So for today, 28th of September, we will be having 5 topics which will be given by 5 distinguished guests. Later I will give full details. So you can share the link for today's YouTube live. This is the link, bit.ly stroke PMTCT day 2. So as a reminder, please register your attendance at the attendance link at YouTube description below or at the link at Webex chat box. Questions to speakers can be submitted using the questions link at YouTube description or link at the Webex chat box. Please ask any questions using the link we provide. Thank you. We will try to answer questions during the Q&A session. If time doesn't not permit, we will try to answer through your email. Some tips: if you want a better, clearer view on YouTube, please go to the setting and choose quality as 720p. And for Webex users, if you have any audio problem, just off your camera or by stopping video, stop video. Okay. So let's begin. Now, without further ado, we will turn the time. Sorry. Now, without further ado, we will turn the time over to the first speaker, who will deliver the topic, updates on management of labor and delivery of HIV-infected mother, how to deal with unbooked cases. It will be delivered by Dr. Muniswaran. The first speaker is Dr. Muniswaran Ganeshan. He is the unit lead and maternal fetal medicine consultant at the Women's and Children's Hospital Kuala Lumpur. He is also the visiting consultant to the National Heart Institute, IJN. He is a member of the Royal College of ONG and was awarded the gold medal for the Masters in ONG from University Malaya in 2011. Having completed his subspecialty training in UK, he initiated and successfully runs the maternal medicine clinic, overseeing the management of patients with complex medical diseases in pregnancy. He has authored and reviewed numerous national guidelines and is a member of the Confidential Inquiries of Maternal Deaths in Malaysia. He has been the scientific chair for various national conferences and is actively involved in training of doctors and midwives in Malaysia and in the region as principal trainer of the intensive course in obstetric emergencies. He has authored 5 books, including the award-winning Handbook in Obstetric Emergencies. His passion is to establish obstetric medicine services in Malaysia and to improve the quality of care of women with medical complications in pregnancy. Dr. Maniswaran, the stage is yours.
Good morning, ladies and gentlemen, and thank you, Dr. Mohammad Izzah, for the very kind introduction. Ladies and gentlemen, it's a privilege to meet all of you all virtually today. And I'd like to sincerely thank and congratulate the organizers for this organization of this wonderful webinar titled Prevention of Mother-to-Child Transmission of HIV and Syphilis. Ladies and gentlemen, having appreciated the management of HIV patients in the primary care, the antenatal management of HIV patients, I think it is apt that we discuss about the intrapartum management of HIV patients. However, ladies and gentlemen, for a more holistic approach, apart from just talking about intrapartum care, I would also like to talk about postpartum care, about breastfeeding, and about contraceptive options among mothers who are retroviral positive. I'd like to declare that I've got no disclosure of interest in this talk. Ladies and gentlemen, in the next 25 minutes, I hope to achieve 5 things. I would like to highlight the management of a suppressed viral load patient coming in labor, the management of a patient with an unsuppressed viral load, patients who present late beyond 28 weeks of pregnancy, what are the breastfeeding options, and what are the contraceptive options. And this is the overview of my talk. Before that, ladies and gentlemen, let's take a look at certain common misconceptions. How can a mother who's got retroviral positive be offered prenatal diagnosis? The answer is yes, especially if they've got a viral load of below 50 copies per mil. Amniocentesis and CVS is not contraindicated. But the first line is, of course, non-invasive prenatal diagnosis. Common misconception number 2. Does a mother with retroviral disease need a detailed scan? The answer is no, ladies and gentlemen. Antiretroviral therapy per se does not cause fetal anomaly. A detailed scan should not be routine among these patients. Do we always need a cesarean section? The answer is no. We have progressed significantly in the last few decades. Mothers with a suppressed viral load can have a planned vaginal delivery. It was a standard of care that intrapartum we used to give almost all mothers zidovudine, but now we do know that that should not be routine. Only a certain selective group of mothers need intrapartum zidovudine. Now, what is the management of preterm pre-labor rupture of membranes before 34 weeks? Is steroid safe? I will address this in my talk. How different should we manage mothers with pre-labor rupture of membranes or spontaneous rupture of membranes? The answer is manage them actively. Is breastfeeding contraindicated? The answer is no, ladies and gentlemen. Breastfeeding among retroviral positive patients are not an absolute contraindication, but there are certain criteria in which you may allow if that is what the patient perceives as something which is important for her and for the baby. I also like to highlight one common misperception. HIV does not equivalent to sexually transmitted disease or pelvic inflammatory disease. It is a different spectrum. It is a different disease altogether. Ladies and gentlemen, we should to move away from stigmatization of patients with retroviral disease. Should we always isolate them separately? Should we always list them on the last case in the operating theatre list? I think we should move away from this stigmatization. I also believe it is a human right and it is the reproductive right of every single woman to be able to achieve her reproductive rights, and we should not deny these mothers their rights for reproductive treatment. And finally, if they are retroviral positive, vaccination is not contraindicated, especially COVID-19 vaccination. So, ladies and gentlemen, before I move on to my talk, especially focusing on intrapartum care, let us reflect on certain commonly known things on what is new. I believe by today, everyone can appreciate the simple concept of U equals U, which is undetectable means untransmittable. And that should be our objective, not in the antenatal period, but in the pre-pregnancy period. Now, I have to bring your attention to this wonderful, recently updated guidelines called the BIVA guidelines, which is a wonderful guideline talking about management of HIV patients in labor. But ladies and gentlemen, let's appreciate one fact. I'm sure everyone by now would have known that we in Malaysia have successfully eliminated HIV, hepatitis B, and syphilis in Malaysia. And I believe we have done a wonderful job, but I believe our job continues, especially because we have got a significant amount of population who are unbooked, a significant amount of them who present late in labor. And these are the cohort of groups that we still need to care sufficiently to eliminate maternal to child transmission of HIV. So, ladies and gentlemen, what is new with regards to HIV? I believe, like any other complex medical disorders, pregnancy, pre-pregnancy care is important. U equals U. Now, there may be certain group of patients who are known as elite controllers, who have got a very suppressed viral load. But we also know now that even this group of patients who are known as the elite controllers also need a combination of antiretroviral therapy. We also do know now that dolutegravir is not contraindicated in the first trimester. There are some association with neural tube defects, and hence a supplementation of a high 5 milligrams of folic acid in the first trimester is important. We also know now that in patients who have got serodiscordant infection, a pre-exposure prophylaxis known as a PrEP, which is a combination of tenofovir and M3-cytarabine, can be given to the mother who has got HIV negative, but the partner who's got HIV positive has a method of contraception. We also know the importance of psychological care, the importance of mental health. And as I mentioned earlier, breastfeeding is not an absolute contraindication. So, ladies and gentlemen, before we move on to intrapartum care, I believe we need to appreciate 3 facts. What is the highest risk of vertical transmission? If a mother presents in labor without treatment, the risk of transmission to the fetus is anything between 15 to 45%, higher if she's got a higher viral load. If the mother presents in labor with treatment, the risk of vertical transmission is 5%. But our current aim is not 5%, it's not 1%, it is to eliminate, which means less than 0.5%. And what are the strategies to eliminate vertical transmission? There are few. Number 1, a combination of antiretroviral therapy for everyone, irrespective of the viral load, even for the elite controllers. Intrapartum antiretroviral therapy, not for everyone, for certain selected group of patients. A pre-labor cesarean section, but more importantly, a pre-rupture of membrane cesarean section. Infant prophylaxis, avoidance of breastfeeding, that is something new, that is not some, but perhaps way forward breastfeeding is not contraindicated. Maternal antiretroviral therapy during breastfeeding, and finally, infant nevirapine therapy during breastfeeding. And these are all the options that we have to reduce vertical transmission. So, ladies and gentlemen, I would like to recap about certain important landmarks that have changed the way we practice. First was the ACTG study in 1994, which highlighted the importance of zidovudine monotherapy. But it have came a long way, and this is not recommended anymore. Then came the PROMISE trial in 2016, which showed that a combination of antiretroviral therapy is far more superior than a monotherapy. Then came the LATE-2 trial in 2017, which showed that two injectable antiretroviral therapies are as effective as a triple oral antiretroviral therapy. And recently, the IMPACT trial and the VESTED trial showed that dolutegravir containing regimens are superior with the lowest adverse pregnancy outcomes. And dolutegravir is not contraindicated in pregnancy, even in the first trimester. So with that, ladies and gentlemen, the essentials of my talk, I'm going to talk that dolutegravir is no longer contraindicated. For patients with raltegravir, you need a BD dosing in pregnancy, not a OD dosing. Patients on zidovudine, patients with monotherapy are no longer recommended in pregnancy. A prenatal diagnosis, an invasive prenatal diagnosis is not contraindicated if your viral loads are low. But it's important to remember two medications, nevirapine and a combination of raltegravir BD dose or dolutegravir OD dose has got a rapid placental transfer. And these two medications are important for every single obstetric unit. And in patients who present late, patients with high viral load, patients who are unbooked, you need 4 agents. And the fourth agent should ideally be a rapid-acting placental transfer agent, either a BD raltegravir or a OD dolutegravir. So with that, ladies and gentlemen, it is important to document an intrapartum plan. If the woman presents in labor being unbooked, it is important to universally screen her with a point of care testing for HIV. Do not wait for a serology. It is not just a viral load, ladies and gentlemen. Although the number 50 seems to be the number of significance, it's important to appreciate the load, appreciate the trajectory and the pattern of the viral load, appreciate the compliance, the duration of which the patient is on treatment. The longer the patient is on treatment, the more suppressed the viral loads are in most instances. And finally, the patient's views and perception of the risk of transmission to the fetus. It's also important to establish obstetric risk and mental health, and then to have a planned delivery, ideally by 39 weeks, and obviously in tertiary centers, which is equipped with neonatal services. Then you need to ask yourself a few questions. Does this patient have a suppressed viral load defined as a viral load of below 50 copies per mil? Or does this patient have got an unsuppressed viral load? Did this patient book late? Does the patient have a pre-labor rupture of membranes or a spontaneous rupture of membranes? Does this patient have a concomitant infection? And these factors should be taken into consideration before you plan and make an intrapartum decision. So, ladies and gentlemen, a slight deviation into obstetrics. Now, when is the best time to deliver someone vaginally? There are now numerous studies suggesting that the number 39 weeks seems to be the best time to deliver a baby. So I'd like to bring your attention to this trial published in the New England Journal of Medicine about 4 years ago, looking into the evidence of routine induction of labor at 39 weeks. It is known as the ARRIVE trial, and contrary to our belief, if you induce someone at 39 weeks, there's no increased risk of cesarean sections, and various other studies showed that it is highly safer for the baby with no maternal risk, with a reduction in stillbirth, a reduction in meconium aspiration syndrome, a reduction in fetal heart rate abnormalities, with no increased risk of cesarean section. Long-term follow-up of these babies also showed a better improved outcome of IQ if someone is delivered at 39 weeks. So ladies and gentlemen, 39 weeks now seems to be the gestation which is of optimal outcome and seems to be the preferred gestation for most obstetric patients. So let's now talk about intrapartum cytobudin. It has been a practice for numerous decades, but ladies and gentlemen, it's no longer routine for every single patient. Only two groups of patients need intrapartum cytobudin. Number one, a patient who is untreated with retroviral positive who presents in labor, or a patient with a viral load of above 1,000 copies per mil who presents in labor and is planned for a cesarean section. However, a third option, which is slightly controversial, but this can be made based on a case-to-case basis, is a woman who has got an unsuppressed viral load above 50 copies who presents in labor and has been planned for a cesarean section. So these are the only three criteria for intrapartum cytobudin. Now, having appreciated that, I think the mode of delivery, we can divide it into two groups. Patients with a low viral load, with a viral load of below 50 copies per mil, a planned vaginal delivery is recommended, and a planned delivery means delivery by 39 weeks, as evidenced by the arrived file. Any patient with a viral load of above 50 copies per mil, the recommendation is to do a cesarean section, ideally between 38 to 39 weeks. So ladies and gentlemen, let's next move into three specific cohort of patients. The first, a patient with a suppressed viral load, a planned vaginal delivery, offer induction of labor at 39 weeks if undelivered, continue a combined antiretroviral therapy. There is no role for intrapartum cytobudin in this cohort of patients. If this patient had a previous cesarean section, a VBAC is not contraindicated, and beautifully, the BIVA guidelines has gone one step further, although it is not practiced in Malaysia, to state that in such patients, even a water birth is not contraindicated. However, ladies and gentlemen, let's look at a different example. If the mother has got a suppressed viral load of below 50 copies per mil, presents with preterm, pre-labor rupture of membranes, you can divide them into two gestations. If they are mild and moderately preterm, if they are below 34 weeks, the recommendation is to manage them expectantly, but steroids is not contraindicated. However, if they have got preterm, pre-labor rupture of membranes above 34 weeks, the recommendation is to manage them actively with antibiotics for GBS prophylaxis, followed by an induction of labor immediately. The patient is not retroviral positive, there may be a role to manage expectantly up to 37 weeks, but in patients who are retroviral positive, the recommendation is to induce them as soon as possible, as to ideally deliver them within 24 hours from the time of ruptured membranes to the time of delivery. Similarly, ladies and gentlemen, if such patients with a suppressed viral load presents with pre-labor rupture of membranes or spontaneous rupture of membranes, they can be delivered vaginally. However, the recommendation is for active management, which means an induction of labor with the hope of achieving delivery within 24 hours. On the other hand, if the mother is unable to achieve an adequate viral suppression, it is important to relook into 5 key elements. Is the mother compliant? Is there a need for resistant testing? Is there a need for therapeutic drug monitoring? Optimize her regime and perhaps intensify her regime. But this 5 assessment is ideally best done with a discussion with your infectious disease specialist. However, ladies and gentlemen, if the mother presents in labor with an unsuppressed viral load, defined as a viral load of between 50 to 399, the recommendation is to have a planned cesarean section, and this should ideally be between 38 to 39 weeks. 38 weeks seems to be the right time because any cesarean section beyond 38 weeks, the mother has got a risk of coming in labor. However, ladies and gentlemen, if you were to deliver them routinely at 38 weeks, the baby has got a 5% chance of having transient tachypnea of the newborn, And in some centers, they do give prophylactic steroids in this group of patients. It is recommended to continue a combination of antiretroviral therapy, but in this group of patients, intrapartum zidovudine remains controversial. The evidence is clear. If they've got a very high viral load of above 1,000 copies, but in this group, you may consider, after discussing the benefits and options with the patient and your ID consultant. So how about untreated women presenting in labor? I believe you have to go back and remember two magic drugs with rapid placental transfer, and these women need 4 medications. First is the nevirapine stat dose, which has got a rapid placental transfer of 200 milligrams. This is followed by oral zidovudine and lamivudine. And please remember, raltegravir 400 milligrams BD, that is the recommended medication, followed by intravenous zidovudine throughout the duration of labor until you have completed the cesarean section. And this is the recommendation of 4-drug regime for patients who are untreated who present in labor. However, the patient presents with preterm labor below 34 weeks with a high viral load. It is recommended to add a double dose of tenofovir because the baby will have problems with absorption and hence a need for a double dose of tenofovir. So ladies and gentlemen, having covered those with a low viral load, those with an unsuppressed viral load, those who present being untreated in labor, a 4th cohort is patients who present late. Similarly, patients who present late, patients with a high viral load, you need a 4-drug regime as described earlier. The recommendation as the 4th agent is to include raltegravir 400 milligrams BD in pregnancy or dolutegravir 50 milligrams daily. How about if the mother has got a HIV and a hepatitis C co-infection? The management, I'm sure it was described yesterday. If the mother's got hepatitis B, it is important to ensure that tenofovir is part of the regime. You may need a higher dose if the mother presents in preterm labor. It is important to check for hepatitis B viral loads. The recommendation is to keep it below 200,000 by 28 weeks. And of course, the mother needs surveillance with regards to liver function test and ultrasound of the hepatobiliary. Similarly, if the mother has got a hepatitis C co-infection, ribavirin-based direct antiviral therapy is recommended. But the mode of delivery remains unchanged even if the mother has got a co-infection, provided the mother has got a suppressed viral load of below 50 copies per minute. So ladies and gentlemen, if the mother has got HIV too, the recommendation is to give a boosted PI-based regime such as darunavir BD dosing. Now, what about certain specific considerations? As mentioned earlier, ladies and gentlemen, the recommendation for a Down syndrome screening is to use a non-invasive prenatal measure. However, if they have got a suppressed viral load below 50 copies per mil, CVS and amniocentesis is not contraindicated. What are your options if the mother has got a high viral load and still needs a prenatal diagnosis? The recommendation is to give raltegravir and nevirapine 2 to 4 hours before your CVS and amniocentesis. If the mother has got a low viral load, can you do an external Catholic version? The answer is yes, it is not contraindicated. As mentioned earlier, preterm, pre-labor rupture of membranes below 34 weeks, the management is expectant, steroids is not contraindicated. Preterm, pre-labor rupture of membranes above 34 weeks, it's important to cover for GBS prophylaxis and to actively induce the mother. And if the mother's got a high viral load, cesarean section is recommended. So ladies and gentlemen, how about postpartum and breastfeeding? Although most mothers were given and would have been initiated on a combination of antiretroviral therapy in the antenatal period, it is recommended to continue this in the postpartum period. It has been a tradition to avoid breastfeeding, and formula feeding is recommended. However, ladies and gentlemen, moving forward, we now know that breastfeeding is not an absolute contraindication among mothers who are retroviral positive. Women may choose to breastfeed provided they have sufficiently and been adequately counseled. And it's important to monitor these mothers with the viral load and ensure that they are on continuous combined antiretroviral therapy. The babies are also being monitored on treatment. Apart from that, ladies and gentlemen, in the postpartum period, mental health seems to be an important concern. It is important to assess mental health 4 to 6 weeks post-delivery and finally 3 to 4 months post-delivery. And please do not forget that this mother needs a cervical cytology 3 months post-delivery. Now let's move on to contraception. I believe we can divide them into two groups. One, if the mother is high risk of having a HIV infection, ladies and gentlemen, there are no contraception which is contraindicated. Even a copper IUCD is safe. However, if the mother is infected with HIV, you can divide them into two groups. Those with a CD4 count of above 200, Depo-Provera's progesterone-only contraception and the combined contraceptive pill are not contraindicated. However, copper IUCD is UK and WHO MAC 2. However, if they've got a CD4 count of below 200, then that becomes an absolute contraindication. That becomes a relative contraindication, not an absolute contraindication. But ladies and gentlemen, I would like to highlight one fact. Having HIV does not necessarily mean that the mother needs a tubal ligation. Having a tubal ligation, the regret rate can be as high as 40%. And as highlighted earlier, we should not deny the reproductive rights of every single individual, irrespective of class, status, disease, and HIV status. But it's also important to understand a concept, ladies and gentlemen. Having HIV does not mean the mother has got a sexually transmitted disease. Having HIV does not mean the mother has got a pelvic inflammatory disease. Why is it important? Because if the mother has got an STD or the mother's got a PID, then of course your intrauterine contraceptive devices are contraindicated, but these are not absolutely contraindicated among HIV patients. Hence, it is important to differentiate these two. The recommendation, ladies and gentlemen, in the modern world of obstetrics is always to suggest a reversible option of contraception, such as an implant-on, such as an IUCD, unless there's a certain obstetric indication on why the mother needs a long-term irreversible contraception. So take-home message, ladies and gentlemen. I believe we should remember 3 medications with rapid placental transfer: nevirapine, raltegravir BD dosing, or dolutegravir. You can use this if you have a mother who is untreated or a high viral load who presents in labor, or if a mother needs a prenatal diagnosis with a high viral load. The number to remember is 50 copies per mil. It is important to plan a vaginal delivery or plan a cesarean section, ideally at 39 weeks. Induction of labor is recommended if the mother presents with pre-labor rupture of membranes or spontaneous rupture of membranes. It is important to try to deliver them within 24 hours from the time of ruptured membranes to diagnosis. However, the mother presents with preterm pre-labor rupture of membranes, please do not forget prophylaxis for GBS and then active management. However, if the mother's got a high unsuppressed viral load, a planned cesarean section is recommended. The correct term is pre-rupture membranes cesarean section. This should ideally be 38 weeks. For those who present late, for those who are untreated, please remember they need 4 drug regimes, and this should include raltegravir or dolutegravir. And intrapartum zidovudine is only limited for a few group of patients, untreated patients in labor, patients with a viral load of above 1,000 copies per ml. So with that, ladies and gentlemen, I would like to bring your attention to four wonderful guidelines. The BIVA guidelines, which is updated in 2019, the Lancet paper on HIV in treatment, the American College guidelines on labor and delivery management of women with human immunodeficiency virus infection, and the wonderful Faculty of Sexual and Reproductive Healthcare guidelines on contraception. With that, I'd like to thank you for your kind attention, and I'll be more than happy to answer all the questions that you have. And please feel free to address any questions that you have. Thank you so much for your kind attention and time, ladies and gentlemen.
Thank you, Dr. Muniswaran, on the wonderful and important updates. We will go ahead and take some time for questions now. Just a reminder for everyone, please be sure to submit your questions at the link at the YouTube description or the Webex chat box link. Just click on the link and you will go to a Google form and you will submit your questions there. Okay, so Dr. Muniz, kindly look at the Webex chat box because we have a few questions for you. Okay, the first question is, if a woman which is unbooked comes to the hospital in labor, will she be tested for HIV and syphilis?
Thank you, Dr. Iza. A very relevant question. I think although we have progressed towards elimination of HIV, I think one of the major concerns are about managing a patient who presents in labor being unbooked. But in Malaysia, yes, we universally screen everyone for HIV and syphilis. So if a woman presents in labor, she will require a rapid test. We don't normally have time to wait for a serology. And if the rapid test is positive, then she will be managed as a woman being unbooked presenting in active labor. So the recommendation is what I mentioned earlier in my slides. IV zidovudine, you do not have time to wait for a viral load. Fast-acting agents such as nevirapine or dolutegravir, and of course the mode of delivery, if time allows, will be a cesarean section, unless she's already in an advanced labor where we've got no time for a cesarean section. So the recommendation, take-home message, yes, universal screening of everyone, rapid point of care test, the woman presents in labor.
Okay, thank you, Dr. Muniz. We have a few more questions for you. I think everyone is interested in your topic today. So the second question is, why fetal infection of HIV can occur during any trimester of pregnancy? I'm not sure how the question is. Why fetal infection of HIV can occur during any trimester of pregnancy?
Okay, so I believe we are possibly asking why and when. So I believe the risk of infection happens when there is a significant maternal fetal transmission. Now, this is highest during labor, and that is why we recommend a cesarean section for those who have got unsuppressed viral load. But can it happen at any time beyond labor? Can, if the mother has got significant antepartum hemorrhage or a significant miscarriage or a threatened miscarriage, but the risks are usually small. So just remember, if there's evidence of fetal-maternal hemorrhage, then yes, the fetus does have a risk of infection, but is usually highest during labor. Hence, it is extremely important not to focus near towards labor, but to suppress the viral loads as early, as soon as possible. Ideally, start treatment very early on in the second trimester, suppress it before she embarks in the third trimester.
Okay, thank you, Dr. Muniz. So here's the third question from Fatasha Zura. She asks, if pregnant lady delivered or born before arrival, patient never had any antenatal booking or screening for HIV before, and when RTK HIV turned out to be positive, how to manage this patient? How then we
Well,
manage this patient? Yes.
yeah, so thank you, Dr. Fatasha. A very relevant question. It is not uncommon that we have these patients presenting late to hospital, these patients who actually deliver at home before arrival. So I think that mother has to be managed as a HIV positive patient, and that baby also has to be managed as a HIV positive infant. Both of them will need treatment. Although the elimination and the risk of transmission, we have actually missed the boat with regards to transmission, vertical transmission intrapartum. They should still be discouraged to breastfeed. The mother still needs treatment, the baby still needs treatment.
Okay, doctor, thank you. So we go to the next question, question number 4. Can we start a late booker with newly diagnosed HIV with Tenvir M with NFV during delivery?
Yes, definitely. The easy answer is yes, you can. Now, the late bookers usually define as 28 weeks and above, but labor can happen at any time. So, yes, that is the recommendation as covered in my lecture. A rapid acting placental transfer agent is recommended. However, if you have suppressed the viral load near towards labor, then you don't need to add zidovudine intrapartum. But she presents in labor or she presents soon after initiation, then she needs zidovudine. So I think there are few considerations that we must consider. It is not just the viral load, but it is more of the trend of the viral load. It is not just when you start treatment, but how long has the mother been on treatment? And compliance is, of course, an issue. And of course, preterm delivery is another significant risk because the fetal swallowing will be affected, gastric emptying will be affected. But a straight answer yes, these medications are safe, these medications are recommended.
Okay, doctor, we have a few more questions because everyone seems to be interested. So that's a good indication, yeah. So the question number 5: if a positive HIV mother wants to breastfeed, how to go about it? I think Dr. Muniz already explained this, but he can explain again. Thank you.
All right, so thank you for highlighting the wonderful controversies about breastfeeding. I think we always have to weigh the balance and risk of every intervention. For example, if you are retroviral positive in Africa, you're actually encouraged to breastfeed because the benefits of breastfeeding far outweighs the risk of the baby having nutritional problems. Now, it has been a traditional practice that we commonly discourage breastfeeding. However, breastfeeding has got a lot of implications, not just maternal implications, but fetal implications. So it's important to select your patients. It's important to counsel them in a non directive manner. Despite sufficient counseling, the mother thinks that it is important for a physical health, for a mental health, and for a neonatal health that she wants to breastfeed and she cannot cope with not breastfeeding, then I think there are certain criteria. Number one, she should be compliant. Number two, she should be on treatment. Number three, she should have a suppressed viral load. The baby should also be on treatment and monitored. So I think it is a combined shared decision making after sufficient counseling. Be selective. It is possible if they fulfill all the prerequisites.
Thank you, Dr. Muniz. So the sixth question by Kamalia. The question goes regarding contraception. If patient is on combined ART or combined OCP, will the effectiveness be reduced? And how is this UKMEC1? I'm not sure what it is. Maybe Dr. Muniz can explain more.
Okay, so wonderful question. I would like to take question number from Dr. Khairul and Dr. Miza together. So the take-home point is no contraception is ever contraindicated in anyone because the risk of pregnancy often outweighs the risk from contraception. However, only certain very few contraceptions are actually contraindicated. So COCP is not contraindicated unless the mother has got a liver derangement. OCPs, POPs are not contraindicated. Now, I think it's always important to check. What I recommend is two classifications. The WHO medical eligibility criteria known as WHOMAC or the UK medical eligibility criteria known as UKMAC. I think it is a common pitfall that we routinely say, oh, this contraception is not safe. I think there is no contraception which is not safe. I believe you should see what is the patient's current risk. Does she have got a normal liver function test? What is the risk of her getting pregnant? And what is the small risk of contraception associated risk to the mother? And then make a combined decision. So the easy take-home message, always check. You can check UKMAC, you can check WHO MAC, you can check the FSRH guidelines, and then make a decision on what you think it is best for the mother. So I'm unable to say that one contraception is contraindicated. I'm unable to say that one contraception is the best. I think it's an individualized decision that you have to make. But basically, all types of contraception, especially non-intrauterine contraceptions, are classified as one.
Okay, doctor. Thank you. So on to the next question from Siti Nordina. Hi, Dr. Muniz. Although lower section caesarean section is recommended for viral load 500 to 399, intrapartum zidovudin is not advisable anymore. What is the minimum duration of infusion intrapartum zidovudin for planned lower section caesarean section with viral load more than 1,000 copies?
Okay, thank you, Siti Nordina. A very relevant question. I will take question number 2 first. What is the minimum duration? It should at least be 2 hours prior to a caesarean section. But usually it is not a pre-labor caesarean section. It is a pre-rupture caesarean section, which is important. So if the mother has got a ruptured membranes, then you don't want to prolong her labor and plan the delivery timely. But however, if she presents in early labor, her os is not fully dilated or she's not in advanced labor, a minimum period of 2 hours is advisable. The evidence is clear. If the viral load is above 1,000 copies, intrapartum zidovudin is recommended. It is beneficial. However, it's the intermediate group, the viral load between 50 to 300 is when you need to make a decision. It is controversial whether zidovudin clearly reduces vertical transmissions in this cohort of group of patients. Hence, it is gray. However, it is not contraindicated to give zidovudin in this cohort of patients. I think sometimes we need to clearly follow evidence. And the evidence says less than 50, you can deliver vaginally, more than 1,000 zidovudin, in between in a case-to-case basis. For example, if the mother is in advanced labor, the mother has got ruptured membranes, the mother has got a co-infection, I would give zidovudin. On the other hand, if the mother has got a very suppressed viral load, she's compliant, she presents in labor, then perhaps you may be selective in not giving her zidovudin. And I would also like to answer question number 8 about OCP and liver function tests. So not all ARTs are hepatic enzyme inducers. So I think we can't generally make a statement that OCP is contraindicated. So I think only a certain selective group of OCPs are actually hepatic enzyme inducers. Although the recommendation is number 1 to check the liver function test, yes, the mother's got a normal liver function test. And if you think that combined oral contraceptive pill is far more beneficial to her, then I think it is okay to give her than to deny her contraception but monitor the liver function test.
Thank you, Doctor. I think that's a final question that you can have a look from Fatasha. Can we allow post date for antenatal mother whom HIV positive with viral load less than 50? And number two, is there any indication of sperm washing for a serodiscordant couple whom who husband is HIV positive, which keen for conceiving?
Correct. I will take question number 2 first. Thank you, Fatasha Zura. A very relevant question. So yes, sperm washing has been recommended as a practice for many years. But I also believe, apart from just practicing sperm washing, it's also important to check the husband's viral load. It's also important to ensure that his viral load is suppressed. And people now talk about PrEP prophylaxis to reduce the risk of the mother having HIV infection. Now let's go back to question number 1. Can you actually allow post dates? The easy answer is yes. Having HIV per se is not a contraindication to induce the mother. However, if you read various guidelines, they say it is good to plan the labor. And no matter how well you plan the labor, it is often unplanned. So based on the ARRIVE trial and based on the current consensus with regards to maternal and fetal benefit, 39 weeks now seems to be the preferred gestation. So we do know that if you induce at 39 weeks, the perinatal outcomes are better, long-term IQs are better, there's no increased risk of cesarean section or failed induction, and it seems to be more planned. So people are looking now at 39 weeks of induction of labor, even for low-risk pregnancies, what most say for patients with HIV. However, I think it all depends on your resources. If you're a busy unit, you can't bring all these women early to the hospital and induce them, then it is okay to induce them at 40 weeks. But in my own clinical practice, I offer induction at 39 weeks.
Okay, thank you, Dr. Muniswaran, for your answers. We are quite surprised with the questions that people are asking for Dr. Muniswaran. Thank you for your commitment. We understand you're at your work, busy at ward. We just had your rounds and came just straight to join us during this webinar. So I thank you very much. So thank you, Dr. Muniz. We will proceed to the second speaker right now, is Dr. Boon. Dr. Boon, are you around? Are you ready?
Yes, can I check that you can hear me?
Yes. Let me introduce you first, Dr. Boon. Is it okay?
Sure.
All right. So Dr. Boon is available at the moment. So let's go to the second topic, which is updates on the management of labor and delivery of syphilis infected mother. Is there any opportunities to prevent syphilitic stillbirth? This will be a very important topic, which will be given by Dr. Voon. Dr. Voon is a maternal fetal medicine specialist based in Kuching, Sarawak. His primary interest is in preventive medicine and screening. He sees himself as a public health obstetrician. A significant part of his work also involves fetal diagnostic and interventional procedure using ultrasound. He was a recipient of the Globe Young Gynecologist Award in 2017 and the Shan S. Ratnam Young Gynecologist Award in 2019, and currently represents Malaysia on the Ultrasound Committee of the Asia and Oceania Federation of ONG, AOFOG, to the 2019 to 2021. Welcome, Dr. Voon. You may proceed.
Thank you for your kind introduction, Chairperson. Can you see my slides at the moment, or do I have to reshare?
Let us wait a few seconds.
Hang on. Right. Is that good?
Yes, we can see it, Dr. Voon.
So thank you. Can you hear me clearly as well?
Yes, we can.
Right, now, without further ado, first of all, I think it's really unfair when I got the invitation from Iza to speak on this topic. I think I'm going to put a lot of you to sleep, because if you ask me, what can be done for someone who is in labor and about to deliver, and the mother is syphilis infected, my lecture ends in one slide. I would say pray, because there's nothing you can do. Whatever damage has been done is there. And I will show you why. And the second reason why I think it's really unfair is that you have my slot to speak right after Dr. Muniz. It's like going to an exam. If you know you're going to go to your final medical school examination, you don't want to be the person speaking after the gold medalist. Okay, you know you might have a higher chance of failing. So I'm going to head straight to the topic today. Now, I have no conflict of interest to declare, and this is the outline of my lecture. Like I said, if you ask me whether there are any opportunities to prevent stillbirth in labor, specifically in labor and delivery, the answer is no. But let's look at how and understand why that is a big no. We need to see with regards to how spirochete is being transmitted. We want to see in women who are already infected, what can we do to reduce stillbirth? So it is the antenatal component which is important. I will not touch on the treatment because I believe that the family medicine specialists are the ones who are treating, and that has been covered yesterday by one of the speakers. But I'll tell you how and what we do to monitor when these cases are referred to us in the MFM unit or in the hospital. And I will talk very briefly about my opinion with regards to labor and delivery in women who have syphilis but are untreated. And finally, a very short section on special considerations in pregnancy. Now, we've all seen this before. Syphilis is a big problem, and all over the world, there is a rebound in cases. And if you listen to Dr. Anita's talk yesterday, she did mention that cases have increased somewhat in 2018 and 2019, although we are still hitting our targets. And congenital syphilis is the cause of death amongst more than 2% of babies who are born alive worldwide. Significantly, a large majority of women who have syphilis without treatment would have adverse pregnancy outcomes. Now, on vertical transmission,
Dr. Woon, we can't really cannot hear you. Can you check back again the internet connection? Hello, Dr. Woon. Hello, Dr. Woon. Hello, Dr. Woon. Currently, we cannot hear your voice. I think there's some technical issue. Can you have a check your internet again? Sorry. Can you hear me, Dr. Woon? Can you hear me? Sorry, everyone. It seems there's a technical issue. We'll try to resolve it with Dr. Voon. Kindly have patience and we hope we can resolve the issue as soon as possible. Sorry. Thank you.
Hello, can you hear me?
Okay. Yes, Dr. Voon. Can you hear me as well, Dr. Voon? Dr. Voon, can you hear me?
Hello?
Hello. Can you hear me, Dr. Voon?
Now I can. I thought we checked this out earlier.
Yes, we did. But throughout the presentation, your sound didn't come up.
But you could hear me initially?
Initially, yes, but throughout the
Okay. No,
previous
that's all right.
2, 3 slides.
Yeah, we can restart.
We
Where were
apologize.
we earlier? At the outline? Did you manage that? Here?
Yes. Yes, doctor.
Okay. Is my screen being shared at the moment? Just let me confirm.
No, not yet.
All right, just a minute. Now I'm happy to start over. Do you want to re-record this? Can you hear me now, Iza?
Yes, doctor. Yes, Dr. Voon, very clear.
Okay, so we'll start again. Now you can see why Zoom is a listed company worth billions and WebEx isn't. Right. So this is the outline of my lecture. We're going to first talk about vertical transmission and understand how the transmission of the spirochetes occur, therefore resulting in the importance of intervention being performed antenatally rather than intrapartum. Right, and antenatal monitoring. All right, thanks for the feedback. So you've heard this earlier, right? Except the spirochete slide. So I'm going to go straight there. So in terms of the route of transmission, it's really important that you understand the essential differences. Let's just compare it with HIV. So the majority of HIV infection, when you talk about mode of delivery, doing a Caesar for untreated mothers, you need to understand it's because the large overwhelming majority of transmission occurs during labor. And you compare this with syphilis, all right? The risk of transmission during labor is almost non-existent, with some exceptions, which we're going to explain later. Right, so largely, in terms of syphilis, the transmission occurs in the intrauterine period. It goes transplacental throughout the pregnancy. Now, you compare that as well with hepatitis, which is treatable now for your information. It can occur anytime. And with GBS, which typically occurs during the peripartum period, right? Chickenpox, only if you have active lesions within the week of infection are you transmissible, and herpes. So what I'm trying to say is Treponema pallidum, the route of transmission occurs prior to labor and delivery, which is why on my initial slide, I mentioned that it's an unfair topic for me to talk about. So Isa, you're taking me out for coffee the next time we meet. Now, the vertical transmission depends on the stage of maternal infection and the duration this fetus is actually exposed to the spirochete within the bloodstream of the mother and the placenta. I will just keep it very simple in terms of early syphilis, and in early I've included primary and early secondary. And then there's the latent phases, right? So in terms of vertical transmission, there's a much higher level of spirochetemia in the initial part, which is why the transmission rates are higher. And that goes down slowly throughout pregnancy. And you will also see that this is consistent with the complication rate of untreated, and I would emphasize on untreated cases. The risk of stillbirth, prematurity, and neonatal death is about 50%. And the other half inevitably ends up with congenital syphilis. They just might appear normal at birth, right? But they inevitably, even though they appear normal at birth, they just don't have early congenital, but they might have late congenital, which appears later. In terms of latent syphilis, the numbers continue to come down, and in late latent as well. So some caveats with pregnancy. Unfortunately, because the primary syphilis is essentially asymptomatic in most women, or has chancre lesions which are painless. And in women who are pregnant, for example, it might be very difficult for them to realize this. They're having so much problem with the changes in pregnancy, nausea, vomiting, abdominal distension, back pain to deal with. They might not have noticed some minor changes in their labia, vagina, or cervix. So some of the authors might tell you that, well, any ulcer, regardless where it is, in a pregnant lady that's indurated and indolent and doesn't heal, a non-healing ulcer, alarm bell should be ringing, okay? Look at her VDRL, recheck it if it's high risk. And any generalized skin eruption, regardless of morphology, can be secondary to syphilis until proven otherwise. Please look back again. Was her blood taken? Did she book late? Does she have risk factors? Is this secondary syphilis, rather than just conveniently assigning this to something like a PUPP? Now, the chancre can appear about 1 to 3 weeks prior to a positive serology, a non-treponemal serology. So it's quite important here. If you look at the lines, the non-treponemal antibodies, they do not rise that early. So you know the infective period, and we've mentioned this many times, the incubation period. So the patient might actually already have this prior to a positive detection. Now, you've seen these slides before a couple of times. This is from the KKM guideline, which they've prepared. Women with risk factors should be retested in the early third trimester. Now, move on to the second part. So are there opportunities to prevent stillbirth? So now we're seeing another woman who has syphilis, and you've treated her in your clinics, but you're worried, you're thinking, well, should I send her to the MFM? But before we go there, I'd just like to speak just on one slide about congenital versus acquired syphilis, because I think it's important to understand the differences. Now, there's no primary syphilis in congenital syphilis. There's no chancre stage. But the underlying pathology is the same. It's the perivascular involvement, right? It is the secondary effect of an intense immune response, not dissimilar to complications from COVID-19, if you may, but the lesions are largely centered on the perivascular involvement, right? Therefore, you would see tertiary syphilis, they all affect the blood vessels largely. But in congenital syphilis, they are rarely localized like in the primary stage. There's widespread involvement because it's hematogenous, it's gone to the placenta, it's gone to the rest of the baby. And you might see all these things, right, in early and late neonatal period in terms of congenital syphilis. What's important is that we recognize that in late congenital syphilis, they might not appear at birth, so don't be too happy. If the titers are high, you still need to treat this baby, right? But the pathology is because of the scarring induced by the reaction to the inflammation. Everyone who's gone to a medical school would know William Osler, and I would like to borrow his quote, and he says that he who knows syphilis knows medicine. I'm going to put it to you that I don't know medicine because I don't know any of these terms. So these are eponyms associated with syphilis, and this is after I've removed half of the eponyms. Look at how widely syphilis has been studied in the past prior to antibiotics. Why do you think we're not seeing them anymore? The antibiotics work. Look at all these terms and all these different presentations that syphilis can give you. That's why Osler himself said, it's the great mimic. And if you understand and you know syphilis, you know different various aspects of medicine, from the eye to the vessels to the joints. In terms of antenatal monitoring, the findings are actually non-specific. So what you would see in fetal infection, you would see in syphilis. So they are quite mundane, right? And what am I talking about? Things that you will also see in CMV, for example, hepatomegaly, fetal anemia, placentalomegaly, polyhydramnios, and eventually leading to fetal ascites and hydrops. That's the baby's liver, and I'm just going to orientate you for those who are less familiar with ultrasound. You can have a look here. That's the baby's head here, the end of the head, and that's the body. That's the arm, as you can see. That's the baby's stomach. That's the diaphragm there, okay? And that's more echogenic area is the bowel. So you can see that this liver is enlarged, all right? And like all radiologists, I also have my moments of hallucination. I'm not too sure whether that's actually hepatomegaly, just because I say it's hepatomegaly. So I'm going to prove it to you. We have normograms in ultrasound based on the gestational age. There's a rough liver length that we can compare, right? And it's in the usual probe that you can use. Scan it in the coronal plane, from the hemidiaphragm to the right liver lobe, right? And hepatomegaly is one of the first findings to occur because of the intense immune reaction and hepatitis. It is also the last to resolve in terms of syphilis. Sometimes it can get very big, not just because of the hepatitis, but because of fetal anemia. And in babies, the liver produces red cells. So it's trying very hard to compensate. It's growing, it's getting bigger and larger. Another picture to show you the hepatomegaly. An indirect sign is the portal vein here. That's the portal vein. And if you put on Doppler, you can see there's color. So there's flow inside. The Doppler vein is really enlarged. Yeah, that's the stomach there. That's the left side of the baby, and this is the right side of the baby. That's the stomach, because the aorta here is on the same side. And well, hepatomegaly is rarely isolated. It's usually accompanied by splenomegaly. You can see here. I'm just going to orientate you again for the benefit of our different levels of audience. This is the spine of the baby, the back of the baby, and this is the front of the baby's chest, in other words. Okay. That's the stomach here, the stomach, and you can see the spleen is over here. It's echogenic, it's enlarged, right? That's the aorta. That's the SVC, and that's the portal vein just now. The portal vein here appears normal, just to show you that it's a splenomegaly. And you also see things like calcification. How do you know it's a calcification, not just a benign echogenicity? If you have some basic knowledge of ultrasound, you would realize that things which are calcified have a posterior shadowing, right? Just like the baby's ribs, or like if you're seeing an adult, you're scanning the gallbladder, you can see things like this. Now, in terms of fetal anemia, we've mentioned earlier, perivascular damage, and there's disseminated changes to these capillaries and blood vessels, and they essentially become more leaky, resulting in hemolysis as well, and some extravasation. This can lead to non-immune hydrops if treated. So this is one of the opportunities for intervention in babies who have been given antibiotics, probably a little late. They are hydropic, so we can transfuse them in utero. Now, in the past, if you want to find out whether a baby is anemic, you would have to do a chordocentesis, as in you introduce a needle straight into the baby's umbilical vein, and you send that off to the lab to look at the HB. Now, in utero and in neonates, the HB is very high. It's usually in the region about 14, 17. So in babies with anemia, they can go as low as I've seen 4 and 2, right? But with the advance of ultrasound, you no longer need to sample the vessels directly. And Mari has proven this more than a decade ago. We use the MCA Doppler. So that's the baby's head there. That's the circle of Willis, if you remember from your neurosurgery. That's front of the baby. That's the back of the baby. That's the circle of Willis. So that's the MCA in the near field and the MCA in the far field. That's the posterior cerebral artery. And you look at the peak systolic velocity, right? You look at the peak systolic velocity. So there are rough rules of thumb. So if I'm seeing a 30-weeker, and the peak systolic volume is about 60, this baby is potentially anemic, right? But if this is a 35-weeker, it's still normal. It depends on the gestation, essentially. And we know that there is fetal anemia if the peak systolic velocity is more than 1.5 times the expected multiple of median. That means that if this baby is only about 25 weeks of gestation, you would expect the PSV to be nothing more than 30, 40, because that's the average, right? So if it hits 50, it's more than 1.5 times the multiple of the median. I'm just going to show you, to reduce the monotony of my lecture, a clip here. I hope you can hear it and see it. Let me know if you can't in the chat box. This is us trying to assess for fetal anemia in a baby. That's the baby's head there. So that's the eye in front. We're trying to look for the middle cerebral artery that pulsates there. So that's the near field middle cerebral artery within the circle of Willis. You have to arrange your gate properly. It has to be parallel. It's very, very important. The gate size and the direction. That's the Doppler there. So what we're going to measure is this peak systolic velocity. All right, as you can see here, it's being occluded there. I'm sorry. So basically, just to show you how MCA is done, and it's really, really quick. I'm going to move on. Other findings associated with fetal anemia include a thickened placenta, and you can see that here. Well, generally, you take about 4 centimeters in mid-trimester as a rule of thumb, but this placenta just looks very abnormal, isn't it? It's thickened, and that's how it appears during delivery. It's pale, it's thickened, it's enlarged. Now, after treatment with penicillin, it's interesting to note, and people have done some studies following up in countries where syphilis is still prevalent. The more severe findings will resolve first, right? So with adequate and timely treatment, even the fetal polyhydramnios and ascites might resolve somewhat, right? And the placental megaly will slowly go away. Hemolysis reduces, the baby reproduces the HB, and finally the hepatomegaly resolves. But please do not think that the MFM can scan everything in the baby. Always a caveat. About 12% of babies with congenital syphilis actually had a normal pre-treatment ultrasound, and they were subsequently, they evolved and they had other findings. Right, and these findings which I've described earlier, well, it doesn't occur, 1 day, 2 days after infection. Remember, these things only occur once the baby is able to mount an immune response against the spirochete, and that usually takes place after about 16 to 18 weeks. And in babies whom already have these findings, you would expect them to have poor response to penicillin. And don't forget, in terms of monitoring, but this is usually handled very, very well by the FMS. We monitor the baby, but don't forget to monitor the mother based on the guidelines in WHO and the ones that KKM has introduced today. The post-treatment ultrasound, the post-treatment surveillance for the mother in terms of the non-treponema titers should be performed monthly until there is a 4-fold reduction or until it's non-reactive, and thereafter 2 monthly until delivery. So I think actually this is the gist of my topic. I was asked to talk about prevention of stillbirth in labor and delivery, and I will still say no chance. Right, so if we're talking about labor and delivery, you come to our labor ward here in Sark General Hospital. A few things we would consider, right? I would think, okay, this mother is infected. Her titer is 1 in 32. We diagnosed her yesterday. She was referred immediately. Well, we didn't have time to give her treatment. So would that change the mode of delivery? Or do I have to deliver her earlier, right? Do we have to deliver at 36? Does that reduces the duration of exposure for the baby? Should we do it at 34 rather than wait for her to go into labor herself? Or can we do an ARM? Can we do an amniotomy? And how are we going to monitor this baby? Does she need continuous CTG, or are we happy with just using a deptone? And when you're monitoring her with the CTG, you can't really get a good reading. Should you actually put in a fetal scalp electrode? Or in terms of second stage management, should we do an instrumental for such babies? And should we delay the cord clamping? So a lot of delivery planning involved, intrapartum, and the second and third stage of labor. I'm going to go through them one by one, but before I do, a reminder that the route of transmission, guys, the damage has been done. Okay, it's all happening prior to labor. I don't think the mode of delivery should change because the transmission is antenatal. In terms of the timing of delivery, I do not think that that should be changed as well, because there's probably more harm in delivering a preterm baby than allowing this baby to go to term and treat it postnatally. One caveat though, if you're giving me a 32-weeker with severe anemia, we've transfused the baby, anemia doesn't resolve, there's still some ascites, and the heart is showing me that it's working overtime, I might consider, in the absence of repeat transfusion or monitoring, we might consider delivering these babies at 37 weeks, because using the Doppler, it's inaccurate after 37 weeks. 38, 39, whatever findings you get, there's a lot of false positives and false negative. Now, although I did say that it will not change my mode of delivery, you might ask me, well, doctor, what if she has genital chancres? Will it not increase the risk of the baby having infection as it goes past the genital tract? After all, you did mention that the bacteremia is highest in labor. Well, this is controversial, and I say there are no specific recommendations because that's not available in the WHO guideline or in the national guideline. So it's on a case-to-case basis. It depends on what the mother feels and how we've counseled her and how we think the treatment of the baby will work. Now, in labor itself, there's no recommendation, again, from our guidelines with regards to amniotomy. But we know in patients with HIV, GBS, where the transmission is very high during the perinatal period, we do not do an amniotomy, right? So you only do an amniotomy if you have to, if you apply the rules of infection. And we don't routinely rupture patient's membrane anyway. It doesn't really increases or shorten the duration of labor more than 1 to 2 hours. Scalp electrode, this is just my opinion, so level 4 evidence at best. Probably avoid if the mother is untreated and in labor, because you might cause trauma to the baby's skin and allow passage of the spirochete. And because it is not an essential intervention, just like amniotomy, it's non-essential. The labor can go on without these two things. You just probably have to think of better ways to monitor the baby. Continuous CTG is reasonable. This is a pregnancy at risk, especially if the baby has other findings antenatally on ultrasound. Instrumental delivery, should we do? Well, generally, there are very few contraindications for instrumental delivery. Some examples are in babies who have hematological conditions, because you might increase their risk of bleeding, intracranial hemorrhage, and SAH. Well, there is potential risk of transmission to the baby if the instrumental delivery is not properly conducted by a trained personnel, very traumatic for the baby. But generally, you do an instrumental for fetal distress, the benefit of that instrumental at that point in time would outweigh any risk of infection to this baby, who can subsequently be treated with antibiotics. Should you delay cord clamping? Very interesting. There's no recommendation, again, from WHO or national guidelines. If you look at HIV many years ago, you would say, well, there's a risk of transmission. Let's not delay cord clamping. For those of you who are not familiar with the hospital setting, delay cord clamping means that after the baby is delivered, we allow the blood from the mother's placenta and the cord to continue going to the baby for about 1 to 3 minutes. There are many papers now to prove that this is beneficial for the baby, especially in the preterm population, to reduce the risk of fetal anemia and iron deficiency later on. It does not increase the risk of jaundice, but in terms of infection, it is a relative contraindication. Previously, we don't do this in HIV, but now we know in the adequately treated mother, there is room for discussion, and we're going more towards yes, more and more towards yes, you can delay cord clamping because the benefit on the baby is significant. In COVID-19, in the early days, babies are separated immediately from the mother if the mother is positive, because we weren't know, we weren't certain. But there are large data now from the Spanish cohort. And remember that in Spain and Italy, it was really bad with COVID-19 at some point. Then they realized that the mothers that they allowed delivery vaginally anyway, allow cord clamping, and let the baby be with the mother for a short period, that did not increase the risk of the baby acquiring COVID-19. So cord clamping is not contraindicated in those two conditions. In syphilis, well, the jury is out. Untreated mother with very high titers, I might think twice in the term baby. Now, just to show you something interesting, this is the Barber's pole. It is what you might see in an untreated mother with subacute necrotizing phenicitis. We're referring to that white, white chalky area here, right? You don't normally see this in a cord. It really looks like a Barber's pole, doesn't it? So this is non-specific again, but it's interesting is what you see in subacute necrotizing phenicitis, which can occur in other conditions as well. It's the Barber's pole for you. And if you look in the cross-section, the chalky white area is here surrounding the vessel. Now remember, going back, understanding the pathophysiology, it is all perivascular involvement. And the placenta, this is how it looks like, pale and large, hydropic. And if you put it on cross-section here, you can see that these are normal, and this is really, really enlarged, hypercellular, so many black dots inside, and with proliferative perivascular changes. If there's an IUD occurring with a positive VDRL, yes, of course, you can probably make a presumptive diagnosis from the cord blood and the mother's blood, but out of interest, you can just do a fetogram, look at the bones, look at how stippled the epiphysis is, right, in these babies. Another caveat I would like to throw at you at this point is that the antibodies can transfer transplacentally, so do not rely solely on the baby's cord blood to look for VDRL. In fact, if I'm not mistaken, and I think the pediatrician will go next, you actually need blood from the baby as well, right? To compare with the mother's titer to see whether this syphilis has actually been treated prior to that. Logically, if the mother has received adequate treatment, her serum titer is about 1 in 4, and the baby is same or lower, you would think that the treatment has been adequate. Now, I must have a slide on breastfeeding. Otherwise, the pediatrician will be upset, and my wife will not speak to me for the next 10 weeks. Postnatal transmission from mother to baby is exceedingly rare, right? So the guidelines, WHO and locally in Malaysia, tells you that there's no contraindication if the mothers do not have active ulcers on the breast over the nipple region where the baby is suckling. Now, one final part of my presentation, some special considerations, and I promise you I will not take up too much of your time now. Penicillin is the only effective treatment in pregnancy to prevent congenital syphilis. Now let that sink in. Not erythromycin, not azithromycin. As of today, not enough evidence yet that ceftriaxone is a good replacement in preventing congenital syphilis. Remember, your end game is twofold: to prevent complications in the mother and to prevent transmission and manifestation of the disease in the baby. Doxycycline and tetracycline can be used in some populations, but they are contraindicated in pregnancy. They cause bone problems and staining to the baby, including the tooth. Very, very effective treatment with benzathine penicillin G. So there are trials to show this as well. Better numbers than your COVID vaccination. And one thing to note is Yarik-Hersheimer reaction. Very important because it's much more prevalent in pregnancy. Doesn't occur immediately. That's why a certain period of observation is reasonable, right? Well, you don't have to keep her in the treatment room. She probably can walk around in your canteen if you're allowed to dine in. They manifest with fever, malaise, sweating, palpitations, joint pain. However, they might have contraction pain as well, because when these spirochetes they die, they release lipoproteins, inflammatory cytokines, and one of the things being released is actually prostaglandins, right? So that causes contraction pain. Most of the time, you do not need to tocilize them. They are self-limiting, right? an important infographic from Queensland, which I got, you will see that it's very, very common, and which is why I'm touching on it. Don't be surprised. 4 out of 5 women experience Jerick-Hersheimer reaction. 7 out of 10 might complain of some transient, and they are almost always transient reduction in fetal movement. 6 out of 10 women experience contractions. And if you put them on CTG, you might actually see transient changes in the baby's heart. Rarely does this lead to stillbirth because of treatment, but it has been reported. Now, it is more common when there's higher bacterial load, right? That makes sense because it's because of the cytokines being released. So just some numbers to show you. Now, and my final caveat to leave you is that false positive VDRL is very common in pregnancy. Don't ask me why. I don't have an answer. Maybe someone can enlighten me. I've been looking for it for a couple of years. Well, not looking hard, but trying to explain. But it's more common in pregnancy, right? And it's also more common in SLE, which are common in women who are young and in the reproductive age. So you always need a confirmatory test. Now, finally, the question and the topic of my presentation. Again, I was asked, in labor and delivery specifically, are there opportunities to prevent stillbirth? In terms of vertical transmission, remember, it is transplacental. Testing, screening, treating with the right antibiotics is very important. And that's why we're having these guidelines. Going back again, labor and delivery, probably no, there's no role. It's just too late. I've taken the initiative to prepare a QR code here. So this is the guideline. This is the purpose why we have such a well-organized sequence of topics by Dr. Anita, Iza, and team, the Garis Panduan, all right? Syphilis is rising. We are still happy, but we should not be complacent. You scan this QR code, it takes you to the MOH website. Right, I'm just going to leave it there. In my final slide, I'm sorry if I bore you with the same slides every time you hear me speak, but it's close to my heart. On the picture on your left, it's a swing when I was training in Sydney. It's a swing for people who are disabled, right? It's just trying to show you that anything is possible. We have to change our mindset. We have to remove stigma. And if you change the way you think about things, anything is possible, right? Who says that a person on a wheelchair cannot have the same enjoyment, the same fun when they're on a swing? Who says that a woman with STD, with HIV, should receive the same treatment, the same stare, the same glance from the public 20, 30 years ago? And as I'm talking about a change in mindset, on the right there is the picture of the lift. I think that was a grocery store somewhere in the central business district of Sydney. Do you see what's different about this lift? And I'm sure you have lifts like this in Malaysia. It's just that the first time I saw it wasn't in Malaysia. So you can see here in this lift, you can sound an alarm. You can call for help. You can go to different floors, right? You can help someone to open the door, but you can never close the door on them. With that, I thank you. I'm happy to
Thank
take your
you,
questions.
Dr. Boon Hian Yan, for your presentation. Indeed, it's a very interesting presentation. It's far from boring. As you mentioned, it's not boring at all. So it's very good that you put a stress on penicillin as the only effective drug in preventing congenital syphilis. And we like the way you ended your talk by mentioning that testing, screening, and testing adequately is the best way to manage the patient with syphilis, pregnant lady with syphilis. So, are you good now for the Q&A session, Dr. Woon?
Sure, I can see the question. Shall I take them directly?
Yes.
So thank you,
Yeah.
Peter Sati.
Okay.
Yeah. But you
Yes,
please
proceed,
interrupt
doctor.
me
Thank
at
you.
any point. Yeah. So thank you, Peter, for your question. Peter Sathi Yanathan. Pregnancy with syphilis. Do we recommend detailed scan at any gestation of diagnosis, even if it's diagnosed late trimester? If detailed scan done earlier and noted some malformation, will TOP be offered? So that's like 3 questions, Peter. That's not question 1. if it's late gestation, I don't think I would scan the woman because you need several weeks for the findings to come out. And there are no guidelines for syphilis per se to tell us how long after infection will the findings manifest. But now again, when there's no data, we extrapolate to similar conditions. If you're talking about things like CMV, it takes about 6 to 8 weeks post-infection for any of those hepatitis and calcification to occur. So if you're telling me 32-weeker, you've adequately treated her, she's very compliant, she's here for a third dose now, and she's 34 weeks, I say, no, you can just monitor her growth. Second question, do you recommend detailed scan? Yes, if it's diagnosed much earlier in pregnancy, I think there's no harm. And the third question is, would you recommend TOP to be offered? And it's very clear here. First thing I have to tell you that we do not TOP for fetal reasons in Malaysia. That is the law, unfortunately. But there are ways where we can support this decision. You would consider TOP if something is irreversible, if something is severe enough on the baby to cause harm to the mother. And please don't refer them to a psychiatrist. You don't need a psychiatrist. In fact, based on our law, you don't even need a specialist to say that this has mental health impact on the mother. The mother is crying in front of you. 2 registered doctors can agree that she has significant mental distress and refer her for TOP. The only caveat is that if you TOP for maternal, if you do a TOP, it must be performed by a specialist in not necessarily in the MOH facility, but it must be performed by a specialist. It must be validated. The request must be valid by 2 registered medical practitioners. So will I TOP? No, simply because syphilis is treatable, and you will, if you were listening to parts of my presentation, I've told you that it is reversible, right? Even if it goes to high drops, if it's solely because of syphilis, which is due to hemolysis with transfusion, but more important than transfusions is actually the treatment with penicillin, right? It's actually the treatment with penicillin that addresses the underlying pathophysiology. The transfusion is merely supportive. We don't transfuse all babies with fetal ascites. We don't transfuse all babies with anemia. Well, the large majority of them with anemia and high drops we do, especially if there's tricuspid regurgitation on the heart. There's a surrogate for, you know, what you would say a low ejection fraction in an adult. So the second question is from Fatasha Zura. Can we allow post-date for antenatally diagnosed syphilis treated with penicillin? Absolutely, Fatasha. I don't think that would change my mode of delivery. One, Aisha, thank you for your question. Can syphilis transmitted through breast milk? I assume you're talking about untreated syphilis, potentially, but remember, you can treat the baby and you can also treat the mother, and you're probably already partially treating the mother when you found out, right? So there's no contraindication for breastfeeding. It is theoretical. It is very, very low. Largely, the pathophysiology is transplacental, not peripartum, not postpartum. Okay, but if you're telling me she has 10 ulcers, weeping from the breast, from the nipple, she's not received a single dose of treatment, I would say yes. But would I say breastfeeding is contraindicated? Absolutely not. She has 2 breasts, start treating her, give her penicillin, give the child penicillin. From Ayman Diana, I'm curious about the mode of delivery. Is SVD allowed or it depends on titer? So remember, SVD is allowed because the perinatal transmission is very low. The damage has occurred. Question 5 from Mizar Nur Fakri. Sorry, I don't think it's from Mizar Nur Fakri. My apologies. From Anonymous. Is it important to know the mother's titer during delivery, the non-treponema titer? Yes, for 2 reasons. Number 1, you want to know whether she's adequately treated or whether she has reinfection in between, right? She might be treated, but she continues to, you know, work in the sex industry, for example, or expose herself to repeated infection. That's the first reason. Second reason, you need to compare the mother's titer. So if you look at the guidelines, please scan the QR code, read the guideline, it's there. It tells you that the mother's levels are important because the pediatrician will want to compare that with the baby, right? And that gives you a better inkling of how severe, what to expect in the baby. From Dr. Muhammad Zafrullah bin Zabri, does syphilis in pregnancy? Okay, I've answered that with detailed scan. Do you audit perinatal death, stillbirth on syphilis? Absolutely. Any stillbirth in Malaysia is audited. From staff nurse Nor Aisha. Doctor, do newborns from mothers with syphilis also need to be treated with antibiotics, CPAN, and need to be admitted to the NICU for monitoring? I shall not answer this question because there's someone more knowledgeable than me. The pediatrician is going to come next, but based on my 4-month experience in pediatrics, yes, you need antibiotics. No, you don't give CPAN. No, you don't need to be admitted to NICU if the baby is otherwise well. Thank you very much. If we have time, I'm happy to take any live questions.
Okay, thank you, Dr. Voon, Yan. I think that's all. You already covered all questions, both on chat box and also from the people who asked through our Google form. We really appreciate your commitment, and we understand that you just had your post call rounds just now, and you must be very tired. So, so we hope that you have a great day ahead. Sorry,
I
doctor.
don't complain. No, you cannot,
Don't
especially if it's
complain.
tired post call, because then the husband will say the
Yeah.
same thing.
Yes, yeah, sure, doctor. So we thank you again. Thank you very much for your wonderful presentation, with very latest updates, and you also had the initiative to make a QR code for the other people who are watching the presentation. So have a good rest, and thank you, Dr. Voon.
Thank you very much. Have a nice day.
All right. Okay, so we already finished with the presentation by Dr. Voon. So for now, it's already 10 a.m. So if according to our tentative, it's already, we will have a break at the moment until 10:30. So we shall meet again at 10:30, everyone. So have a good break. Okay, Assalamualaikum. And how are you all? I hope everyone had a good break just now. Now we hope you are ready for our third speaker today. We will talk about two topics, which are, the first topic is updates on management of infant-born HIV positive mother. The second topic is updates on management of infant-born syphilis positive mother. These two topics will be given by Dr. Chu Chong Ming. Dr. Chu is a consultant ID pediatrician who currently works in Hospital Pulau Pinang. He has actively been involved in PMTCT or EMTCT programs in Malaysia for the past 10 to 20 years. He completed his undergraduate studies in 1992 at University Malaya and obtained his master's in pediatrics at HUSM in 1999, and also got his fellowship in pediatric ID, Westmead Children's Hospital, Sydney, Australia in 2009. His area of interest is pediatrics, HIV or TB, primary immunodeficiency or infection, and immunocompromised hosts. Dr. Chu, you may proceed. You may proceed. Are you around, Dr. Chu? Can we have a test of your voice first, Dr. Chu? I think you are muted, Dr. Chu.
I will start my
Okay.
slide. Okay.
All right, Doctor. Thank you. I'll leave the floor to you, yeah?
Yeah, sure. Okay, can you all see my slide?
Yes, Doctor, we can.
Okay, thank you so much, Mr. Chairman, for the kind introductions. Okay, now we are almost at the end of the programs of the second days. And as you all know, the pediatric side, we are going to be the last mile period of these EMTC programs in Malaysia. I was given the task to present on two topics. The first one is on the prenatal exposure of a baby to the HIV, and the second topic on syphilis. So I will start out with my first topic first, okay? All right, this is our Malaysian HIV/AIDS progress report in the MOH 2000. And you can see from here actually the number of pediatric HIV below 1 year and also those 1 to 14 years is almost zero. This show a very, very low incidence. And this is probably, you all know, is attributed to the very successful PMTCT program that started many years ago. And this is a snapshot of our Malaysians 2019, the number of people living with HIV. As again, you see, number of children are much less as compared to the adult populations. There's only 301 of them who are below 50 years old. And they might actually, most of myself and my PITS colleagues, most of our patients actually now are maybe more than half our patients are more than 12 years old. And fortunately, we have very few pediatric HIV new cases was detected in the same year. We only have 18 cases was diagnosed in the year of 2000. But there's still about 4 deaths among the small number of pediatric cases. All right, but this is not the focus of today. Today, we are still talking about preventions rather than treatment of these diagnosed cases. All right, as you all know, most of the children got the disease via vertical transmissions or so-called maternal to child transmissions, more than 90%. And majority of those vertical transmissions actually happen at delivery, about 50%. And the other 1/3 was probably due to breastfeeding practice. And very minor, a small number of them actually do acquire HIV via blood transfusion. I think at the moment I got 1 or 2 cases under my follow-up which is non-vertical transmissions. And fortunately, I do not see any case that acquire HIV by sexual abuse in Malaysia so far. And as you all have seen from the previous slide from the earlier speaker, the risk of vertical transmissions can be varies from actually as low as 13% to up to about more than 1/3, up to 42%. And the reason why there's a wide variation because the data is getting from many areas in the world, and as you know, many factors actually do affect the risk of the MTCT transmission of HIV. But with the very effective interventions, we managed to reduce the incidence to as low as 2%. And in my setup, I would say I was lucky that I see probably less than 0.05%. I got very few cases who failed the program so far. Okay. And this is another slide from WHO. It mentioned that around 1.4 million of HIV infections among children were prevented between the year of 2010 until 2018 due to implementation of the PMTCT service. And in 2017, 80% of pregnant women living with HIV were receiving ART. And this showed a significant increase from the year of 2010 level when only about half of them have access to ART. And this is one of my slides that I do share with every of my this PMTC programs. It's a start, it's a cut snapshot from the start on Sunday, May 16, 2010. It was from that we know that this Malaysian's PMTC program has started more than 20 years ago. From Dr. Anita lecture on day one of the this webinar, I was know that the actual program is started in 1997, but probably it's only rolled out nationwide in the 1998. Okay, and when it started, the program is cover only women receiving antenatal care at government facility. But at that time, it was estimated around 70% of total antenatal mother nationwide were found to utilize government antenatal services. And coverage of this mother through public safety improved from about 50% in that year up to about almost 100% 10 years later in 2009. And even though there's quite a significant number of mothers to get their antenatal care in private sectors, but many of our private colleagues actually refer those mothers to government medical schools. So in other words, we are covering almost all our antenatal mothers. And this is a summary. I'm not sure that Anita has shown you on day one, probably just a quick look on that. You see, for the past 10 years from 2010, definitely there's increase on neonatal antenatal attendance, and number of screening of HIV, number of screening of syphilis. Definitely it show a nice improvement, and we almost achieve a very high rate at the year of 2019. At the same time, you can see the HIV seropositive, especially, you see a constant downtrend, but probably not as good when you look at the green line, which shows syphilis. My next topic, I'm talking about syphilis. And you can see here, so there was a downtrend from 2020 until the year of 2017. There's an uptrend of a sudden uptrend of this congestive syphilis. I hope somebody actually looking into it. What's the exact reason for that? But this trend actually not only occur in Malaysia, it has happened in US as well for the past 10 years. They found actually numbers of CS definitely increasing for the past 10 years. But fortunately, and look at the HIV incident, it remained almost flat up at the end of the last 3 to 4 years. All right, this is the timing of MTTC. As I mentioned earlier, the estimated MCC rate is about 30 to 40% the highest actually. And how much of this proportion, when this happened, and this has been shown by the slide by my early team members. As you know, most of this happened, this transmission, medical transmission actually happened during labor and delivery itself. And another big portion probably had to happen at the postpartum period, mainly via through the breastfeeding practice. But we do have a small proportion of them get early infections as early as below 36 weeks, also a late antenatal from 36 weeks to labor. And very small, another small percentage actually happen in early postpartum period. Okay, the timing of ARV prophylaxis and MTCT. This basically show you the slide, the first, this gray color bar actually show if you do nothing, there's no interventions. This is, of course, this paper, the data is from the Western, published in New England Journal of Medicine in 1998. Without any intervention, that can be as high as almost 30%, 26.6%. And if you just focus on postpartum intervention, the risk is still very high at 18.4%. But look here, if you do the antepartum, and intrapartum and postpartum immediate management in less than 40 hours, you can actually drastically bring down the risk to as low as 10% and below. All right, there's as I mentioned, there's many factors that associated with higher transmission rate, but the most important factor is still the viral load of the mothers. If the viral load of the mother is not increased, so all these other factors become less important. I'm not going to repeat because most of these factors have been mentioned by my colleague in the earlier topic, in the earlier bits. So now come to the chief part of my presentation on HIV exposure on infant. So an infant born to a HIV infected mother, what to do? This is a question that we need to ask ourselves. So the first question is the baby infected? So most infected infants are well and asymptomatic at birth, as infection rarely occur earlier in pregnancy, as you have shown by earlier speaker in their lectures. Most status of the baby actually remain unknown when they are born. But the common signs do occur later in infancy if you miss the cases. So they will come back later at the age of 1 to 2 years or up to 5 years old. They will come to validify. If this manifests the ACE form of disease, they may come with autotrans, chronic diarrhea, hepatosplenomegaly, and some of them come with opportunistic infection like PCP pneumonias. And another common feature we see in pediatric HIV is the generalized lymph node enlargement. All right, come to diagnosis. I know that Dr. Noemi would want to talk more about the laboratory parts of both HIV and syphilis diagnosis. But just let me touch a bit on what's the difference of diagnosis, making a HIV diagnosis in young infant, especially those below 18 months old. And as most of you know, maternal antibody interfere with the HIV ELISA antibody test. And it can persist up to 18 months. And I do see cases who have they have non-seroreversion up to the age of 2 years. So definitely serology itself is not a good method. And a diagnosis needs to be confirmed using biologic tests. And here we are talking about molecular techniques. And now I think at the moment, this PCR of HIV DNA and RNA is still only available in MR. We hope in the future these tests maybe they can come at least to the state lab. But as Dr. Wood mentioned just now, do not use cord blood because maternal antibody to pass to cross the placenta, and it will make your interpretation result difficult. But the sensitivity of the baby serums can be as good as 90% by 1 month age. So HIV DNA RNA PCR test for HIV exposed infant, preferably we'll do as early as 0 to 2 weeks, depend on whether it's a high risk mother or low risk mother. For more, the higher the risk, the earlier we need to do because there's a possibility of earlier vertical transmissions. And second test usually we do around age of 6 weeks, when a baby was 6 weeks old. And the third test is the final test that usually we do after the age of 4 months. And bear in mind, this, as I say, is very sensitive and very specific. They can detect very early infection just days or weeks after the exposure. So if the PCR for HIV is positive, we should repeat as soon as possible because we still need 2 tests to confirm the diagnosis. And these 2 positive HIV PCR tests must be taken as a separate day. But bear in mind, this PCR test seldom came back as false positive, and we should not delay the treatment or refer or maybe to the pediatricians or PID if you strongly suspect the child to have infections. Okay, so diagnoses are almost excluded if you have 2 or more negative PCR tests at the age of more than 1 month, and one of which is performed at age more than 4 months. And of course, here I'm talking about in an asymptomatic baby who are otherwise totally well. Okay, and we can say that we can tell the parents that I'm quite certain that your baby is not infected if all 3 PCR tests are negative. And of course, we need to confirm with a seroreversion, as I mentioned. Usually I don't do it at 12 months, a bit too late. But of course, some cases serorevert very early as 12 months. Usually we do the antibody test, the earliest I will do when a child 1.5 years old. And sometimes we might delay up to 20 months, depends. Okay. So we have all the 3 PCR tests negative and the antibodies on mother have disappeared. Then we can quite certain and tell them is confirmed the baby is not affected. And again, I must stress the baby must remain well and asymptomatic. Okay, now come to the question of what should we do? The management of this baby even started before the delivery process itself. I think, as you know, the antenatal counseling is very important. And I think the most important fact that you need to tell the mother, the risk of transmission can be as high as up to about 50–40% without any interventions. So it's very, very important for this group of mothers to get a proper antenatal care. And feeding practice, even though the baby is not born, it's always good to start the counseling right before even as early as during the mother's first antenatal visit. We have to inform the mother this is the fact that the risk of transmission double by breastfeeding. Even though in a fully viral suspect mother, the risk is double itself. And right, we must also must understand from my earlier slide, it's very difficult for us to make a clinical diagnosis. We can't tell by just looking at baby, this baby is infected. So we have to stress the importance to mother. It's very important once the baby born, he or she will need a regular blood test and a close follow-up by the physician or the patient in charge. So infant care and delivery, probably this is not so important as most of the cases are now born in hospital in a very well-controlled setting. But yet we still need to remind, we have to practice standard precaution at all times and always use protective barrier during delivery. I'm sure you all are very familiar with PPE now in the midst of our pandemic COVID-19. So during handling of placenta tissue, during handling of the baby, like suctions or wiping off the liquor, all equipment should be clean and sterilized. Okay, and even though home delivery is very uncommon nowadays, but to remember, if the case the baby to happen to be delivered at home, you should use any battery operated suction device and try to avoid any manual suction that might actually causing trauma to the baby or to the mother. Advise the same precaution for parents related with handling the placenta. If the baby used to be born, died, or so-called stillbirth, or dead baby at home, this is very important. Placenta should be soaked in the formalin before disposal, or sealed in plastic bag or leak-proof container, and not to remove it after that. Okay. So what happened after delivery? So of course, most of this baby, if they are well enough, they don't need any intensive care or ventilation. We will admit them to a nursery or special care nursery or ward. And of course, the first liner, the doctors, especially housemen, need to take a very thorough maternal history and also perform a good or quite a complete newborn examinations. And we should remember that HIV baby, we shouldn't just focus on the HIV exposure itself. Other common neonatal problems need to be taken into consideration as well. We need to review if there's any other problems. Of course, other congenital infections highlighted by the fetal and maternal specialists. You can get toxoplasmosis, you can get cytomegalovirus, and of course, hepatitis B and C is still very important in Malaysia. And I know that probably most states have started doing routine antenatal screening for Hep B and Hep C as well. And of course, syphilis is another topic that we are going to discuss later. And then TB is still endemic in Malaysia. So, and you know that TB actually is we so-called good friends of HIV. Yeah? So HIV-TB co-infection is very common as even among the pregnant ladies. And don't forget drugs. Drug abuse is quite common in Malaysia, and to ask for any symptom of drug withdrawals in the mother who might actually have history of taking drugs. And most babies are actually, I say, they are well, they are asthmatics, and they only require routine infant care. People will ask me, what blood investigation do you need to do? Yes, you need to have some baseline, at least a full blood counts, and we do a routine baseline liver function test. Of course, HIV PCR, especially if you think the child is born by a high-risk mother, that you want to get PCR diagnosis as soon as possible after birth. So Hep B, surface antigen, hepatitis C screening, tortures, as I mentioned, and syphilis serology as indicated. And we should start, the most important thing, start the antiretroviral treatment as soon as possible, preferably within 6 hours of delivery. And this is one of the major KPI for all the pediatric infection disease specialists in all the major hospitals. So we should give either syrup zidovudin with or without nevirapine. I will further discuss on this regime later. So now we come back to the bit of case scenario for infant that require antiretroviral prophylaxis. I'm actually using this Malaysian Peace Protocol 4th editions, which was probably a little bit outdated because they are supposed to came out with a new edition every 4 to 5 years. But because since the protocol have been still widely used by my peace colleague as well as some of the non-pediatric discipline in the country, I don't want to do much changes to avoid any confusion at this point. So the scenario one is when we are dealing with a mother who have low risk. So these are infant or pregnant lady who already on antiretroviral treatment and has very good virus suppressions, which we define as not detectable, depend on the lab service that you're using. And I think in the moment, most guidelines we define as less than 50 copies per microliters. So in this group of baby, it's quite straightforward. We give this NRTI, zidovudin at a dose of 4 mg per kilo per dose, not per day, 4 mg per kilo per dose, twice a day for next 4 weeks. Okay. So we come to the next scenario when we have infant at higher risk of HIV acquisitions. Example, infant born to HIV infected mother who have the following conditions. The mother have not received any intrapartum or antepartum treatment, ARV. Okay, or the mother only have received only intrapartum ARV. That means the diagnosis only made upon the mother present at delivery. Or those mothers who have received antepartum treatment but does not have documented viral suppression before the delivery. So in this case, in this type of scenario, zidovudin 4 mg per kilo per dose in two doses for 6 weeks instead of 4 weeks. We are actually prolonging it to up to 6 weeks, and we need to add on the another drugs. The commonly used drug are nevirapine, which is belong to the NRTI groups, at a dosage of 8 mg per dose for those with birth weight of less than 2 kilo, or 12 mg per dose for those with birth weight of more than 2 kilo. Don't worry so much about the dose. I'm sure you can get it easily, clearly documented in the guideline that available in your center, also as well as in most of the KKM website. So, but remember that this nevirapine dose, especially for my PITS colleague, is a bit, you need to be careful. The first dose of nevirapine is given as birth. That means it's 0 hour of life at birth itself. And then the second dose actually 48 hours later after the first dose. And the third dose is 96 hours after the second dose. It's not as 0 hour, 48 hours, and 96 hours of life. A lot of people confuse. So in summary, you give a first dose at birth, and then by end of day 2, you give the second dose, and by end of day 6, you give the third dose. So most of these high-risk baby, preferably I still like to keep them in the hospital setup because I think probably quite difficult even for the doctors to remember the timing and dose. I think it's not that safe if I leave the task to the mother at home. So of course, if you look at the some of the latest guidelines, especially for Western, some experts actually advocate that we use a triple ARV regime, and this is especially in the setting that you actually presumptive, we offer a presumptive HIV therapy to baby have high risk of getting infected. So and the regime they recommends is AZT, lamivudine, and then plus either nevirapine or letercravir. I think letercravir probably we don't have the appropriate formulation in Malaysia yet, especially for newborn. So if you do use, I'm not sure any of my colleague, PSID colleague in Malaysia actually using this, but I myself, I hardly use. I will only consider when, so certain case, I really think that maybe have very high risk of getting infected, and probably I would rather, because I think the reason behind why people, why experts suggest presumptive HIV therapy is there's a lot of good advantage, a lot, especially in the form of the immunological advantage, as well as the risk of resistant, viral resistance eventually if you start the treatment on the baby as soon as possible. But I won't touch on detail. If you have any interest, you might on this, you might ask me later in the Q&A session. Okay, the dosage of syrup Zirudin, as I say, you can easily access. But now we are talking about premature baby, as we know that we do have quite often with HIV mother actually came in for premature deliveries. So the dosing a bit different, depend on the gestation age of the baby. If below 30 weeks, we give 2 mg per kilo 12 hours, 12 hourly from birth to 4 weeks. Then 3 mg per kilo for the subsequently next 2 weeks. Remember that for high-risk cases, actually, I think most of the premature baby, probably they are more often in the high-risk mother. So you need to give the drug until up to 4 weeks. The dosage only different in the last 2 weeks. And for those more than 30 weeks of gestation, the earlier dose is same, 2 mg per kilo, 12 hourly, but up to 2 weeks. From 3rd week onwards, the dose is being increasing to 3 mg per kilo, 12 hourly from the age of 2 weeks up to 6 weeks if the child do require 6 week ARV prophylaxis. Okay, and some cases we know that baby are ill and you can't offer oral feeding or oral medication, then you might consider using IV Zirudin at a dose of 1.5 mg per kilo per dose. This is all quite clear cut and shouldn't be any problem on this. Okay. Okay, so all this baby that born to a HIV positive mother who have risk of HIV exposure, how are we going to follow them up? Okay, usually we'll review them at least the first round at the age of 2 weeks. Except this baby, we are kept in the hospital for other neonatal issue that they are still warded. Usually, as I say, even the high risk cases, we will discharge them within a week. So normally we call them back in 2 weeks. And then we see them, if for low risk cases, actually we do not take the PCR. So we only do the first PCR at the age of 2 weeks. And then following by the second PCR, which we usually do at the age of 6 weeks. And then after, if the baby remain well and quite no other major issue, we can see them quite safely, see them only every 2 to 3 months. Okay. And what you do during the follow-up, you have to look for any drugs intolerance. Okay. And of course, even though most babies do not manifest signs and symptoms earlier, but you'll be still searching and asking history, is there any sign or symptoms such as HIV infections? Okay, why the patient is still on Zirudin? I'm sure most of you are aware that there's a problem of Zirudin. This anemia related to Zirudin is quite common. Okay, and you need to look at after your baseline full blood count at birth, you need to check whether the baby have anemia at age of 2 weeks and 6 weeks as well. And as I mentioned just now, you take the PCR test at 2 weeks, 6 weeks, and for the third one at 4 to 6 months later. Okay, another question is when do we start this Bactrim prophylaxis? So normally after we stop the ARV prophylaxis at age of about 4 or 6 weeks, the Bactrim prophylaxis should be start for pneumocystic canine infections. While we are waiting for whether the baby is confirmed to be infected or not. This is just a form of prophylaxis. But Bactrim usually can be stopped by the age of 4 months of age when we receive at least 2 negative PCR results. As I say, most probably the baby are not infected when you got 2 positive PCR results. So if all the 3 PCR results are negative, then we can actually follow up the child 6 months after that. And as I mentioned just now, you like to repeat, you need to do the serology to check whether the mother antibody have disappeared by the age of 18 months old. Okay, but don't panic. You go to get, we do have cases that came back, the antibodies are vaguely positive. It's quite not that rare. We do have a number of cases. So normally, if these cases are not under healthcare side or not under any specialist follow-up, to refer back to the specialist so that they can counsel the mother and do not create any unnecessary anxiety. Normally, I will repeat it at least about by after the age of 20 months, provided the baby is well. If the baby is unwell, of course, if you suspect the baby might have an infection, then I would strongly advise you probably instead of doing waiting for another few more months to repeat serology test, you can actually do a core MR and whether you should repeat a fourth or third or fourth PCR test. So if negative, then the issue becomes very clear cut. Baby is seen yearly and followed up at local health clinic until the school age, they're reaching school age. Okay, how about if it's so unfortunate the baby get infected? Of course, you have to stop this ARV prophylaxis immediately. I think not a good idea to treat any HIV infection with monotherapy. Okay, and then of course you have to refer. If your center have a PIS ID like me, you should refer to me. If not, then refer to a senior or a pediatrician who have trained in managing pediatric HIV for further management or early to consider started early ARV. I think at this point, almost most of the state in West Malaysia, except one or probably a few, 2 or 3 states that don't have PIS ID. Same have applied to East Malaysia. I think Sabah and probably very soon in Sarawak we should have at least one PIS ID services there actually. So in case of this baby infected, of course we can't stop the vaccine prophylaxis. We have to continue until at least age of 12 months, and then later we need to reassess the baby immunological status, see whether they still need to proceed with this positive infection prophylaxis. All right, come to the dosage of Bactrim. Remember, Bactrim is a combination antimicrobial therapy. It consists of 2 antibiotics, trimethoprim and sulfametazole. But the active component in Bactrim prophylaxis, actually we are referring to the trimethoprim. So the dose should be calculated based on the TMB dose. Do not confuse. And it does happen that some this medication error to occur from time to time, because sometimes when we prescribe as a TMB dosage and the dispenser thought it's a combination doses. So please write it clearly. Your dosage is based on TMB. Normally, I still use per weight because to calculate body surface area, especially in a young infant, is quite difficult to get their exact height. So I advise you use 4 mg per kilo per dose and make it life easy. Some people like to ask me, Dr. Chu, should I do it alternate day? Should I do it BD or whatever? I think to make it easier for the mother, just take it on night before the child sleep or something. Just give 4 mg per kilo. And of course, sometimes you have very rarely we have some baby who are not for some reason they are either allergic to Bactrim and Bactrim is contraindicated. Then you have to look for alternative, which is Dapsone, which is not a good choice of drug because it will have more toxicity. And pentamidine, I'm not quite sure whether we have in Malaysia. I think we don't have it in Malaysia. But fortunately, I will say so far I don't have problems most of my baby. And even some people to question whether Bactrim can be given with baby with G6PD deficiency. And if you really read under the literature, the risk of acute hemorrhage is actually not high, even in baby who have G6PD deficiency. But anyway, you have issue, you refer to the expert and also discuss with your in-house pharmacy about the choice of alternative prophylaxis. Okay, this is probably another hot slide that I don't want to open so much. I will call it maybe some debate actually. From the latest evidence we have, if in case a moms, well, maybe the mother are not pediatrician. I'm a pediatrician, but I must tell you, I'm not obsessive about breastfeeding. Okay, no denial that breastfeeding, we know that there's a lot of advantage of breastfeeding as compared to infant formula. But here in Malaysia, I just need to make things very clear and simple. We do have a very safe alternative in Malaysia. Okay, we have a safe alternative, and the government are willing to provide you a free infant formula at least for the first 6 months until your baby are safe enough to receive feeding food. And as far as I know from my health side colleague, most health centers have no problem to supply the HIV mother with free infant formula up to the age of 2 months. So whether you belong to B40 or belong to M40 I hope our rich people don't need the help from government for the infant formula. There's no issue of whether the baby will have malnourished, like in what another speakers mentioned in African country, when you don't allow them to breastfeed, the baby will die from malnutrition initially. This kind of thing shouldn't happen. Will never, I would say, should not happen in Malaysia. So we do counsel the parent mothers, say that from the facts and from the data we know, infant formula, in fact, I can say it's a safer in view of you have a possibility of baby can be infected by a disease that cannot be cured. I need to stress the instant. It's only been controlled by medication. It's a disease that you might pass it to your baby and the disease cannot be cured at this point. So it's probably too expensive. Whatever advantage that you got from infant, your breastfeeding, whatever bonding you get, probably not worth to trade off by letting your baby have a risk of infected by HIV. But if you do have any concern, please do let me know and let's talk it openly. And of course, I advise those center that those staff that you feel uncomfortable, you feel a bit not confident to talk about it, especially if you deal with a mother who have very strong feeling about breastfeeding. Do refer to the next expert that you can get hold of, especially your FMS, or even your FMS can refer to a nearby pediatrician that you know who are good in doing this kind of counseling to the mothers. But I do agree with Dr. Anita and the rest of our team member that we need to respect the mother right. We cannot force them. Even though we say that we advise you for exclusive infant formula feeding, and we advise them breastfeeding as far as possible should be avoided, but it's still your right, your decision, and you can decide at the end. But another thing I would like to say that when you talk about human right, don't forget the right of the baby itself. As a patient, I can tell you, not 100% of the parents at the best for their children. In fact, we pediatricians are the one who advocate the best for the children, probably not the parents, because this is probably sometimes because of the lack of knowledge. We know the child, the moms love their child, but they probably don't know what's the best for the child. So as professional, we need to guide them and we need to give them counseling in a very professional manner. That's what I like to stress. I hope if any question we can discuss it. If anyone still have any concern about this Malaysian policy on exclusive infant formula to all our infant born to HIV mother. All right, this is another question, another slide that probably I think some of you have asked in the previous Q&A sessions about immunization of baby born to HIV mother. Generally, I would say all vaccines that include under the KKM schedule are being well tolerated by our infant exposed to HIV. So you just give all the vaccine according to the MOH schedule, but there's some special precaution for live vaccine. Sorry for I think for the spelling mistake, it's LIVE. So BCG should be omitted in HIV infected infant who are symptomatic only. Only those who are symptomatic and those who have evidence of severe immunosuppressed. I hope I answered the question from a young lady in the group earlier. She asking about should we give BCG to infant born to HIV mother? Yeah, we should give the baby appear well, and we think especially those baby born to low risk mother. But we think the risk is very high and the baby is symptomatic and not well, then probably to withhold it until the status of the baby is ascertained. Polio vaccine, very fortunate we don't have oral polio vaccine anymore. I think the whole world, I don't think any country in the world are still using a live polio vaccine. We have all shipped to this inactivated polio vaccine. Measles, you omit if HIV infected children with severe immunosuppression. Measles is quite easy because usually we give the first dose of measles, it's the earliest we give. Even in Sabah, it's up to about only age of 6 months. By then, you should know whether this baby is infected or not. And if the baby infected, we should have know what's the viral load, what's the seasonal count, and whether the baby can be given measles vaccination. And as you all know, pneumococcal conjugate vaccine have been made available for all infant born in Malaysia on and after the 1st January of last year. Okay, this is called Prevalent 13. So this is a conjugate vaccine, it's not live vaccine, so there's no contraindications. How about chickenpox or varicella vaccine? Yes, you should offer if affordable, of course, because we do not give it as part of the KKM or MOH under the KKM schedule. Of course, this varicella vaccine is a live vaccine you should avoid in any HIV infected child with CD4 count less than 15%. Okay, this is just a summary. I don't want to repeat it. So the definition of immunosuppressed here is when your CD4 count percentage, not the absolute count, not like adult, they use absolute count of CD4 count to define immunosuppressed. In children, we define 15%. Because you know, the younger the infant, their CD4 count actually higher, much higher compared to adult. Okay. All right, I think it's almost end of my talk. Let's go on through one, I would say quite interesting case, this baby of age. He was born last year in July, about a year ago. He's a premature baby, 31 weeks, was born via emergency lower cesarean sections because mother was diagnosed HIV positive in labor, and the baby birth weight is only 1.39 kilo. And this mother, she's a 37 years old lady, and she has history of multiple sexual partner during her teenager years. So far, she already had another four living children with her, and she had one previous car in the year of 2018. The emergency system decision was made because the team that received her that time not aware that she had HIV before, and they only found out when her rapid test turned out positive. But actually, her HIV had been diagnosed in the year of about 9 years, more than about 10 years ago. She was diagnosed in 2011, and she was previously under infectious disease physician follow-up, but unfortunately she reported on and off. Her hepatitis B, hepatitis C, and also fortunately she's not positive for syphilis. She's a GPS positive carrier actually, you know, but she don't have a prong rupture membrane. And the high vaginal swab done on the day of delivery, actually, they noted there's group B streptococcus beta hemolytic was positive. But the liquor was clear, and unfortunately, this mother passed away after the delivery due to the cryptococcyemia with meningitis. So infant was admitted to our NICU. Of course, because of the prematurity, she had quite evidence of RDS. She was intubated at birth, and the cerebral replacement therapy was given at around 7 hours of life. We managed to establish the baby at day 2 of life, but unfortunately she deteriorated and require reventilation at day 3 of life and was treated for nosocomial pneumonia. And very unfortunate, after the mother passed away, no relative came, and the baby was abandoned for a while in the ward. So we did a further history for mother. She was diagnosed with RVD or HIV in the year of 2011, when her first child was admitted at the age of 5 years old due to prolonged fever. Upon further investigation, noted child have a positive serology for HIV. Hence, she was screened and noted HIV positive too. Second child screened, but fortunately it's negative. That time she claimed that her first husband is infected screening test was negative. Initially, she followed up at the state hospital on first line antiretroviral therapy with Combivir and Efavirenz in the year of 2011. And the doctor, they actually give her a dose of this course of isoniazid prophylaxis for latent TB. Subsequently, we have to shift her treatment to second-line treatment on tenofovir, amitriptyline, and nivolumab in the year of 2012 due to so-called intolerance to first-line ARV. Her side effect actually is not very clear-cut. She compared a lot of weight symptom, headache, muscle pain, and such. Because the doctor have concern of a complaint, they decide to change the management for her, change the drug for her. But unfortunately, despite doing that, she still defaulted in the 1 year after that. At a 5 month of pregnancy when she had conceived her third child, and then we only have managed to restart her back on therapy after delivery of the child. And again, very fortunate, the third child was screened but negative. Again, she defaulted in March 2015. I think this is a very good case scenario. I remember one of the participant asking the question, how do we deal with mother who keep default our follow-up treatment? Probably now I'm throwing back the question to the audience. How do you handle? She was again defaulted in March 2015 after she divorced with her first husband. She married the current second husband and moved to another state. So in April 2016, they noted her treatment failing again. There's a viral treatment failure again. That when her CD4 count had dropped to 270, her viral load had went up to 38,000. And second husband screen, and again he's negative. And the husband, the second husband denied any high risk behavior. So the mother was started back on treatment in September 2018 after delivery of fourth child. But again, both herself and the baby default medical care 2 months after delivery. I think they went back to the homestay. They went back they come over to Penang, then they went back to Kelantan, the homestay. Unfortunately, we don't know because the fourth child was not screened fully by our side, so we don't know the fourth child status. The fourth child. Only later, we found out the fourth child actually being adopted like one of their relatives. Her last viral load was noted only in November 2018, which was very high at 120,000. And as I said, she moved back to homestay and lost follow-up after that. So she only come back to us this time when represent with the current center in July last year because of the premature referral of her fifth child. And her last CD4 count was only 7, almost 0. Right? So in other words, I can say that, and eventually she died from what? She died from AIDS, cryptococemia. And of course, we don't manage to get her viral load before she expired. So it's a very sad, it's a very complicated cases and rather sad story actually. So this is still the question that I would like you all have a think about it. Could we avoid the death of this HIV-infected mother and improve the outcome of all her children, or at least we reduce the risk of transmissions of HIV to all her children? And then what is the risk of vertical transmission to especially to the fourth and fifth child? Because the first, second, and third child we don't have much. Of course, the first child already infected. First child already infected. Second and third child negative, but we don't have much info. But how about the fourth and fifth child? Do you all think it's high risk or low risk? I'm sure you all agree with me. Since her viral load is very high and she almost come with at one stage of HIV, the risk for child is very, very high. But fortunately, with as I show you the earlier slide, you do compared to we are not doing anything at all. We are not doing anything at all. By started even as late as we just managed to start the intrapartum management, the intervention is started intrapartumly. We can manage to cut down the risk, and it's very good, very fortunate that actually both the fourth and fifth child was turned out to be negative, despite their risk can be as high as more than 10 or 20%, compared to most of our cases, which I say the risk is almost 0%. But another thing we have to think back, look, after I tell you all the detail, what are the major hurdles that could have contributed to the treatment failure of the mother and increase the HIV risk exposure to her children, to all her subsequent children? I think, again, this child, this case, if you remember back the history, she was start off, maybe she's not high risk, she's a teenager mother. She had some sexual promiscuity. I'm not sure whether she actually take drugs and so on. That one we don't have the history on that part actually. But even though she claimed her first husband negative, we are not sure whether she acquired HIV as early when she was a teenage or actually she acquired the infection from her first husband. Okay, and then come back to the question for the mother who keep default and keep moving away from us. Actually, what should we do? I think this is probably an issue that more challenging than what we can imagine. But I'm sure a lot of the ground staff here, they agree with us. We do encounter this kind of mother from time to time. Actually, either they are foreigner or either they are local Malaysian. This lady is a local Malaysian. So this is definitely this case we need a more holistic and more multidisciplinary approach. We need to involve the family members. As you know, from the history I give you, hardly any info we can get from the family backgrounds. Even though I was told the fourth child and finally the fifth child, we managed to avoid infection in the fifth child. We managed to, I think, but unfortunately the default after the first discharge from our side. I think after 1 month discharge from our side after the baby have achieved good weight up to 1.8 kilo. We refer to the social welfare. The social welfare actually managed to find for us one of the relative, I think probably from the husband, for the second husband side, one of the ladies from the husband relative willing to adopt this child. And I called my colleague from one of the district hospital. They say actually a mother and a child both is under follow-up by one of the local health center there. And I was told the last PCR actually for the child was actually negative. So it's still a good story, a good ending for the mother, for the child. Sorry, unfortunately we lost a mother, that mother. So I think certainly, from this case we can learn a lot. We can actually, I'm sure there's some good thing that we can do in the future. There's some remediation we can be taken in future to prevent similar case. Okay. With that, I would like to thank your attention. I hope I keep myself on time. And all right.
Okay, thank you, Dr. Chu, for your first presentation. We'll go ahead and take some time for questions now. I think we can allow up to 2 questions, yeah, Dr. Chu?
Yeah, sure.
Okay, you can have a look at the chat box, and there are 2 questions. The first one is from Nofatma. How to screen and follow up HIV test for child of 2 years of age whose mother just diagnosed as HIV and the child was exclusively breastfed by mother before. Antenatal screen was negative before.
So if for children more than 2 years old, it's make our life is much easier. I think unless your first ELISA test on baby turn up to be negative, and clinically you still strongly feel that this baby, which I think unlikely, even though if the baby got infection from breastfeeding, of course people argue whether it could be some window period, like an adult with 6 months of window period. Depend on assessment of risk. If the child is definitely very high risk, then you're not happy, you're still not, you don't believe on your serology test. And if the child do have symptoms as mentioned, let's say the child do have some features of early HIV or late HIV infections, then probably you still need to go for PCR. Otherwise, I think a serology test of negative or positive will be quite useful, either to diagnose or exclude infections. So we still use 18 months at the cutoff point. Below 18 months, you need PCR, molecular testing, but above 2 years and above, you can actually quite safely use a serology test to diagnose. Of course, when you confirm, before you start treatment, we still need to get a baseline viral load and PCR. Maybe we still do that actually. Yeah. Okay. Sorry, not PCR. It's a viral baseline viral load and CD4 count. All right. That itself actually help you to confirm your diagnosis. Okay.
Okay, doctor, thank you. We go to question 2, doctor.
Yeah.
Do you recommend COVID vaccine for children with HIV positive?
Okay. This question, I'm sure a lot of us are very interested to know what's the indication of children, since we are starting to vaccine of children 12 to 17 years old, and I do have more than half of my HIV patients belong to this age group. The concern of COVID-19 vaccine on this group of children, immunocompromised patients, is not so much of contraindications. There's no contraindication. In fact, they might need the ventilation more than you and me. They are higher risk of getting severe COVID-19 rather than you. So the question is, how effective? Can we settle them down with only 2 doses, or we need a so-called enhanced, or you want to call it a 3rd dose? I'm not talking about booster here. I'm talking about the primary vaccination itself, how effective. That is still remain unanswered. Definitely, I've registered all my patients, include the non-HIV patients as well, to go for this vaccination. If you do have any cases that under your care, I strongly advise you, because they need to get a letter from doctor and their consent that taken by you before they can either, some state they are walking in and some state they are waiting for the call by the my SJ appointment. Okay, either I depend on which state you belong to. So I strongly advise, it's not only meant for the patient, but it's also meant for the whole country. We need to advocate this. There's no question that they need to be vaccinated. I'm talking about HIV alone. Of course, if there's other contraindication, you have to discuss with the expert that taken care of this group of children. If there's any other contraindication, but we are not using AZ or other vaccine. We're only using Pfizer at the moment. We are still using the mRNA vaccine for our HIV kids. And the only concern now is about myocarditis. But we already stressed to a lot of the doctors and the public as well. the risk of you getting myocarditis and die from myocarditis due to COVID-19 is much. I can't overemphasize this. Much higher than rather to getting the complication by vaccination itself. All right. I hope it's make it very clear cut to everyone. Okay.
Okay, Dr. Chu, I think thank you for your answer. I think that ends our Q&A for the first topic. So can we go for the second topic, Dr. Chu?
Yeah,
Are you
sure.
okay?
I think I have no problem with that. Actually, I will go
All
to
right.
the second topic. Actually, I will
Okay,
share back my
okay.
screen again. All right.
Okay, Doctor. So just a reminder, our second topic will be the updates on management of infant born to syphilis positive mother. Dr. Chu will give it as well.
Can you all see my screen or not?
Yes, we can see, Doctor.
You can
Just
see my PowerPoint screen, huh? Okay. Okay, my
PowerPoint not yet,
second,
Doctor.
sorry?
PowerPoint not yet, Doctor. It's
Not
still
yet.
showing your folder,
My photo,
your
then how do I
PMTCT folder. Maybe you should close the first presentation first,
Okay, all right.
and then open
Close.
the new presentation.
Okay. I should stop sharing first. I think I have to come up from it. Okay. Okay, can you see now?
Yes, Doctor. Yes, it's clear, Doctor.
See now, all right, okay. So let's go to the second topic on management of infant born to mother with positive serology for syphilis. Okay. Okay, I will go through this slide quite fast because I think it will be taught by the other speaker as well. So of course you all know it's syphilis is caused by this organ Treponema parietum. It's a thin mobile spirochete and extremely factitious. That means it's very difficult to grow it. And it survives very short lifespan outside the host, just like virus. Okay, it doesn't survive long. And transplacental transmission from infected mother at any time during pregnancy will be highlighted by other speakers as well. Risk of infection, yes, could be as high as 90%, especially if mother have untreated primary or secondary infections. Infection do not result in inflammatory changes in fetus until after first trimester. Yeah, despite that, it can happen early, but it's not that causing all the major changes, features until after first trimester. And surprisingly, organogenesis not affected, but can cause stillbirth, as pointed out by the fetal and maternal specialists. And preterm is quite common, hydrocephalus and IUGR as well. Risk of infection depend on stage of maternal syphilis and the duration of in utero exposure. Fetal infection result from hematogenous spreads, rarely caused by direct contact with maternal infectious genital lesion as birth. I think this again highlighted by other speakers. Fetus infection usually result in extensive inflammations and multi-organ involvement. So the longer a woman has syphilis before pregnancy, less likely infant will born with congenital syphilis or die in utero. So if you have early stage of infection, because the mother will have very high viremia, very high spirochemia, very high spirochemia, result in almost 100% risk of vertical transmissions. And 4 years after infection, it can be still as high as 70% chance of transmission rate. But for late latent maternal syphilis, most infants are unaffected. So as you know, the syphilis are being congenital syphilis are being divided into early or late. So the early onset congenital syphilis are those diagnosed before or at age of 2 years of age. So 60% of them appear. More than half of this baby actually appear normal at birth, but symptomatic develop within 2 months. But the symptom, how bad was the symptom is actually varies depends on how the extensiveness of the organ involvement. But those common features are enlarged liver and spleen. Then you got the large liver and spleen, and also abnormal liver function test. Other features include the bullous rash, anemia, rhinitis, or the other term they call it snuffles or rhinonia rose, with highly infectious nasal secretions. And if you perform a X-ray on their long bone, you can see some characteristic bone changes, include osteitis and preostitis. And sometimes the child can present with pseudo-paralysis due to the bone involvement itself. Okay, for late onset congenital syphilis, usually result from untreated infection, and I hope it seldom happens nowadays with a good this EMTCT program. And it only diagnosed the case when the child was more than 2 years old. And this is a classic triad we known as Hutchinson triad. The baby have this notch central incisor tree. They have sensory neural deafness, and they might have interstitial keratitis that led to blindness. And other features like saddle nose, anterior shin bowing, linear scar around the mouth. And 60% of infants with congenital syphilis had actually this brain involvement, CF involvement. More likely, if this is a secondary maternal syphilis or happen in early latent syphilis. All right, this is some of the cartoon of pictures that we show. The picture, this is very classic. You can see this typical, this kind of bullous rupture, bullous rashes, especially over the palm, the sole of the feet, actually. And this is a typical saddle nose. And you see this rhinorrhea, beware of this. This is very infectious secretions, actually, right? And this is a classic so-called Hutchinson T triads you got in the late onset congenital syphilis. And the linear scar, you can see this over the upper lips here. And this is a classic features of the long bone changes that involve the bone, osteitis and preostitis. Infant born to a mother with positive, positive serology test, either a positive RPR or TPPA. I think there's a audience asking what's the difference between VDRL and RPR. Actually, basically they are the same things. VDRL is just an older version of test. I think at the current I think probably all the lab in Malaysia we are shifting to this RPR. Both VDRL and RPR actually are the non-treponemal tests. Okay, they are actually not specific, but they are very sensitive tests, and they can have they are actually diagnose the disease entity rather than the diagnosis of the disease itself. Whereas TPPA is a treponemal test, which I think Dr. Rani will elaborate further on that in the last lecture of today. The other test that treponemal test that we have in the past is TPHA. One is using the heme acoustic technique, and this is using a particle acoustic. So don't be so worried about this. So just remember, RPR is a non-treponemal test, and TPPA are the treponemal test. So does baby have congenital syphilis and need treatment? This is a same question that we ask just like baby born to HIV mother. So we want to know whether the baby is infected or not. So to decide that, of course, why you want to know whether baby is infected? Because you want to decide whether you want to treat the baby or not. So the first question you should ask is, does mother have syphilis? Is it? And if the mother do have syphilis, what stage of what type of what disease is it? Is it primary? Is it secondary? Is it early latent or is it a late latent syphilis? And then the next question is, was the maternal syphilis being adequately treated by whoever who have managed the mother? And come to the third question on the infant, is there any clinical, any lab or X-ray evidence of congenital syphilis on this child, as I mentioned in my few previous slides? And why is infant and mother RPR treated at delivery? This is, I can't stress this because I found, especially in the past, these are not being done. Either, especially the mother RPR being missed when at delivery itself. So come to this question: does mother have syphilis? So diagnosis of maternal syphilis have been elaborated by the previous speaker. I don't need to go into detail, but you must remember the confirmation of diagnosis of syphilis cannot be done through a microscopic dark field examination or direct fluorescent antibody test of the lesion or exudate or tissue. This is a very definite, very accurate and very definite analysis, but specimen is usually not reliable. And unfortunately, they also have very high false negative rate. So for that reason, we still have to go back to serology test to diagnose maternal syphilis. As I say, this is the test. The TPPA is a specific test, but remain reactive for life even after treatment. I think one of the speakers used the term, they call it syphilis scar, okay? Just like a scar you got after burns or other cuts. So it remains in you on you forever. So the TPPA, once you are confirmed syphilis, diagnosed syphilis, the TPPA or TPPA will remain positive for life. It will never disappear, okay? Whereas for the RPR or VDR, it's a very cheap and rapid non-tribal test. I think I was told only few cents per test, so very cheap. It's a quantitative testing, not only positive or negative, but it will give you an exact detail. And they're very useful for screening and also monitor of disease activity and how well the patient has responded to treatment. But bear in mind, you can have a false negative RPR, especially in the early primary disease and also the latent and late disease. And at the same time, you can have a false positive RPR for certain other medical conditions like EBV infection, SLV lymphoma, and many more. Okay. So identification of mechanism is important for prevention and detection of congenital syphilis. Routine RPR screening on first trimester, as you all know, for all mother, and usually now in the national guideline, we repeat all at 28 to 32 weeks. And as again, we also repeat the mother RPR at the time of delivery. So info on treatment of husband and sexual partner is very important, and we need to assess because this is very useful for us to assess the risk of reinfection for both couples. And screening of infant serum of cord blood is not reliable, as mentioned earlier. And this what I call it, test could be negative if mother serology titer is very low or infected and late pregnancy. So don't be so so relaxed if you found the baby actually, especially a high risk baby. At the end of the day, when your baby was born and you found the RPI is negative, it could be because the infection just happened very early. Not as contrast to the PCR for HIV I mentioned, it can detect very fast even after days of infection. But RPR probably will take some time to come in before it turns positive. So was infected mother adequately treated? This is again a very important question for us pediatricians. With appropriate penicillin regime, it must be treated only with appropriate penicillin regime. As I mentioned by one speaker, there's nothing else except penicillin are being accepted as the treatment for syphilis. So be careful if the mother are being treated as non-penicillin regime. And it's very important that mother being treated at least more than 1 month before delivery. So treatment failure can occur if the treatment happened at the last month before the baby was born. And as far as possible, you want to document that mother have been responded well to treatment by showing us at least there's 4 times reduced in the RPR titer, and or at least after treatment the titer remain low, because as you know the infection can occur. And bear in mind, some women, because they are poor response in terms of serology, they have this serophastic and the titer may not come down as expected. Okay, and again, you must check husband RPR, you must check husband TPPA, and repeat if necessary. Even the husband have found it positive initially, doesn't mean the husband cannot get infected eventually. So definition of mother complete treatment, I think this you can find in most of our guidelines. So mother was treated with adequate penicillin regime as per national or local treatment guideline. They should receive 3 doses of treatment for case of late syphilis or unknown, or you are in case you are not known. The stage is not known. Let's say you have a mother come to you, you are very uncertain what stage of disease she's having. I think it's advised, as some of our local guidelines strongly advise that we give 3 doses of iron penicillin. And the duration between each dose is 1 week apart. And if the interval between the 2 doses is more than 9 days, this may be a bit controversial. I'm not sure certain state or certain experts may not agree. They say as far as the treatment is still happen within 1 week, they accept. It's happened within 10 days, it still accept. But in certain state or certain local guideline, we define if the duration of interval between the 2 doses is more than 9 days, then the treatment is considered inadequate and you might need to repeat the dose again. So, and we make sure that the treatment is complete at least 30 days or more prior to delivery and no possibility of infection. That means the mother, as far as she should be a single sexual partner, or the husband have no risk of get infection or reinfections. And that's why we need to document that there's at least a 4 decrease in the RPR titer following treatment. But as I say, some mother, they might be a non-respondent in terms of serologically. If you're very confident you have treated the mother accurately, yet the RPR titer remains static of not coming down as expected, it's always good to take out your phone and discuss with the expert, either a nearby SMS or dermatologist, or even Dr. Tyler from Sungai Buloh, as I know he do involved in treatment of maternal syphilis as well. This is for us to ascertain the mother's stable status. All right. So this is probably repeat of what this is the reverse side. I don't want to repeat it. I already mentioned in my previous slide. So the definition of mother who are treated and the definition of mother not treated, I mean any of the requirement in treated mother are not being fulfilled, we say this mother are not treated. But the other point I need to highlight is if the mother have high likelihood of reinfection, be careful. A lot of mother, these syphilis mother, they have very complex, very complicated background history. Their nature. Some of them actually are sexual worker if found. Yeah? Most of the time, when the partner bring them in, the so-called partner actually not their partner, it's their business partner, not their life partner. Actually, So so this kind of mother, they have a high likelihood of reinfections rather than other mothers. Okay. So evaluation of infant for clinical lab and radiological syphilis, all infant or mother with positive serology test must be thoroughly examined for any sign and symptom of congenital syphilis. And RPR or infant serum, not cord blood, as I need to stress again. But again, many doctors ask me, do we need to do GPPA or not, or so-called this confirmation test? I will ask back the same question, the question to you. If mother is confirmed syphilis, why you need to confirm GPPA on the baby? Because you know the risk is definitely there if mother confirms syphilis. And bear in mind, GPPA is detect the IgM embryo. Theoretically, we thought as medical students was taught IgM cannot cross placenta, but in the real life, we do detect many babies to have these IgM antibodies, triple number antibody from mothers. So even though you got a positive result, you cannot tell whether it's from the baby or from the mother. And of course, as I say, there's up to about 60% of cases might involve the brain, the syphilis actually can go to brain. So you consider perform a lumbar punctures and did a cerebrospinal fluid examination. But I know many of our cases, the parents actually refuse, so they don't allow us to do. So in that case, we have to just treat a presumptive meningitis. And of course, X-ray long bone and check X-ray may be as indicated, depend on the clinical assessment. So why is so important? I stress that we need to do the infant and maternal serology titer at the time of delivery. So the infant RPR should be interpolated in comparison with maternal titer. Infant test may be reactive or non-reactive, depend on timing of maternal and fetal risk infections. As I say, if the fetal infection just occur right before delivery, then the baby have no enough time to develop RPR. So it's good for you to know what's the mother RPR and the baby RPR. And preferably, I think both of this mother and baby RPR should be done at the same time by the same lab personnel and using the same methods in order to take out other confounding factors. So even after appropriate treatment, maternal antibody can still cross the placenta, result in a positive test in uninfected infant. So at the same time, this reminds us not to overdiagnose. In asymptomatic infant, RPR is only considered significant is more than 4 times or higher of the mothers. Both mother and infant sampling at the same time, as I mentioned, tested in the same lab. Infant with clinical or tissue evidence of disease, any positive RPR strongly support the diagnosis. Even the baby who are negative RPR, when you have clinical features or X-ray changes of syphilis, you can still make a diagnosis of congenital syphilis. So this is a guide for interpretation of maternal and infant serology test. Maybe I think I give you all about just 30-second channel how to interpret the 5 answer. How do you interpret the RPR in mother and infant and the TPH in mother and infant? So if all the RPR negative for both mother and infant and TPA negative for both mother and infant, what do you think? If only the RPR is positive but TPPA is negative on both mother and infant, what is the possibility? And if let's say the test is the RPR is positive on mother, the RPR on infant is positive or negative, but the TPPA is positive on both mother and infant, what is the possibility? And then if all the RPR and TPA is positive in both mother and the infant, what is this? And then at the end, only the TPPA is positive in mother and infant, but RPR is negative in both of them. Can you get a quick answer now before I give you the next slide? Okay. All right. Okay. This is how we're going to interpret that. Okay. So as I think most of you get it right for the first one. If all are negative, that means both mother and child are not infected. So, but if only the RPR is positive, but the TPA negative, then it's most likely this is a false positive mother with the RPR passively across the placenta to infant. So this is not a syphilis case. Okay, it's unlikely to be syphilis. This one. Okay. So if the TPPA is positive on both infant and mother, but the baby RPR is either positive or negative, then the maternal syphilis is still possible. Yes, it's treated or either a latent syphilis, and there's a possibility that baby is actually infected. Okay. And of course, if all the tests are positive, so there's high likelihood either the mother have recent or previous maternal syphilis, and of course, that's possible for infant infection, depend on whether mother are fully or properly treated or not. Okay. And if only the TPPA is positive, as I told you all, the TPPA will remain positive once you have infection. So that means mother have a treated syphilis before, but she don't have active syphilis at the moment. Or of course, mother can rarely we can have a false positive TPPA as well. And in both scenario, and then the infant is very unlikely to be infected. Okay, all babies should be treated unless the following apply. Okay, so we as a pediatrician we tend to overtreat the baby. As of course here we're talking about EMTCT. We want to eliminate conjunctivitis. So sometimes we tend to a bit overtreated. So mother was actually treated with an appropriate penicillin regime, then only we will not consider to treat. So unless the following apply, I mean, except this happened, otherwise we'll treat all the baby. And mother was treated at least more than 1 month before delivery. And mother antibody have been documented fell down, coming down at least 4 times at least after the treatment and remain low at delivery. So, and then we need to exclude possibility of reinfection on mother. And of course, the baby must be physically normal. You cannot find anything on baby, and baby RPR low and not higher than mother. And follow-up of any untreated baby, you need to ensure that you must ensure you're able to follow up the baby. If you have any concern, this baby might not able to follow up, then you might have to think of giving treatment or at least prophylaxis to the baby. So treatment regime for candidate syphilis or presumed infected or possible syphilis, again like in adult, there is only one choice. That's one we only can give penicillin is the only drugs to give. And here, because we are talking about early syphilis, especially, we are giving IV penicillin at the dose of 30 mg per kilo or 50,000 units per kilo. And the dosage interval need to be a bit careful here. At the first 7 days of life, we give it in a divided dose, 12 hourly for the first 7 days of life. Then from 8 days onwards, you increase it to TDS doses for the 8 days onward, not the duration of treatment. Let's say you start the treatment at day 5 of life. That means day 5, day 6, and day 7, you give 12 hour doses. But by the time day 8, you have started to increase the dose to TDS dose. And duration is 10 days standard, but you have to extend it 2 weeks if any brain or CNS involvement, or if you've got an LP done, the cerebral spinal fluid actually involved. Alternative, for some reason they don't want to stay in as a hospital, or it's not practical for them to come back for daily IV injections, then maybe you can consider giving IM prochloroquine penicillin 50,000 units per kilo daily for 10 days. But bear in mind, I'm sure you all know, even though the dose for baby may be much lower than adult, it's quite a painful injection for this prochloroquine penicillin. Okay, sorry. Okay, mother with positive RPR, but baby asymptomatic RPR is negative. How about this case? Mother, you may consider single dose of IM penicillin, especially you think this baby could have a possible incubating syphilis. And following that, you need to do a close serology follow-up for this baby. Follow up the baby, okay? we need to do careful physical examination, and we advise to do serology testing at the interval of every 2 to 3 months until the RPR become negative or decrease at least 4 times. By right, this RPR should decline by age of 3 months, and most of it become negative by age of 6 months. If either the baby is not infected or if the baby is adequate fetus, that's what we expect. So you consider to restart the treatment of baby if there's clinical signs and symptoms or any persistent infection or recurrent infections, or the RPR fail to decrease or become persist or increase after 6 to 12 months of treatment. For infants with who have initial cerebrospinal fluid evaluation are abnormal, should undergo a repeat LAPA puncture in 6 months. But I must tell you, in real life, most parents are quite reluctant to let us do it because the baby otherwise look well, especially. But if you have repeat and this test and the reactive cerebrospinal fluid VDR RPR test was positive, or any abnormal cerebrospinal fluid incisions that cannot be attributed to other ongoing illness, then you require a retreatment for possible neurosyphilis. So if the cerebrospinal fluid is improving, we just monitor and follow up their serology test, the blood serology test. So for infant not treated and follow-up cannot be ensured, as I mentioned now, there's an option to give a single dose of IM benzathine penicillin 50,000 units as an early prophylaxis to this cohort baby. Okay. So come to notifications. I think because I'm giving up this slide to some people asking me, let's say the baby are totally well, totally well, especially now, should we still notify them as syphilis? Yes, if any the RPR titer is more than 4 or higher, then what the mother, even though despite the baby looks so well and the mother are treated, everything, you still have to notify because it's very unusual for the RPR of titer of baby are so 4 times higher. And of course, if baby with clinical features of syphilis, you need to notify as well. But other than that, in any situation that you suspect CS or conjugal syphilis, I think from the KKM policy, we still advise you to notify because eventually when the case was reported to us, the national committee will clean up the data eventually. We rather you to report rather than we miss any case. All right, I think I need to open up another, probably for this. Later, if I have time, I think I will share the algorithms with you all. Because this, I found this hyperlink doesn't work very well. This is a algorithm that I developed, mainly to be used by my local staff in Penang, and how when have a positive baby born to a positive mother, a step-by-step approach. If I have time, I try to open up the algorithm later. So before that, I will go for some case. I think I have time. I'm right, Dr. Iza. I still have some time. I can go through 1 or 2 cases for you all. Baby born term, 11th of August in 2016. Weight was 3.5 kilo, clinically well and no symptoms. So he referred to the pediatric team for infant born to mother with positive RPR. So the baby RPR titer was 1 in 2. And unfortunately, the result only arrived to us about about day 5 of life, about 5 days later. And the blood CNS had no clue. So, and unfortunately, again, for this case, the mother RPR at delivery is not done. Her last RPR about 3 weeks before delivery is 1 in 8. So what do you think? Is the baby, these cases, what do you think? Is it, you think the baby should be treated as conjugal syphilis or not? So let's see the more history on the mother. Her mother is 25 years old. She's para-1, diagnosed syphilis during pregnancy. Her TPPH is positive, so it's confirmed she's had maternal syphilis. RPR dilution detections on 21st of January was quite high, 1 in 32. So they give a first course of treatment started in February itself, and mother complete 3 doses of iron penicillin by 1 month's time, about 17th of February. And look at her titer, but despite that treatment, her titer had been just slightly dropped by 2 times from 32 to 16. Then it went up to 32, then it go down to 16 again. That means the mother titer remained fairly high at 1 in 16. So thus the local health team decide to give her another course of treatment. I think this happened about 1 month. Yeah, it happened within about 1 month before the baby was born. And then again, they repeat the titer on July. Then this round, the titer actually came down to 1 in 8. And they screened the father as well, and father was found out to be positive 1 in 2, but we don't know when the date of result, not stated. So come back to the question: does the mother have syphilis? I think most of you agree with me. Definitely, mother has syphilis because her TPA is positive and her titer is as high as 1 in 32. So to come to next question: was maternal syphilis adequately treated? Is the answer yes or no? Yeah, I think the first round, yes, we are not very certain because the first round of treatment, her titer actually came down from 1 in 32 to 1 to 16. But fortunately, when they after the second round of treatment, about 1 month, more than a month before delivery, the mother titer eventually came down from 1 in 32, the highest came down to 1 in 8. So 1 in 8 is about 4 times below the previous titer. So in other words, we can say this mother are treated adequately. So as you know, the baby was born otherwise well. He's a term baby, and there's no clinical lab or X-ray evidence of syphilis. So in that case, I think you all agree with me. Most probably, this baby is not infected. But of course, here I think we didn't have the mother titer adequately. But baby titer was quite low when he was born 1 in 2. And of course, some people argue whether 3 months, 3 years ago, can he use? Of course, it still gives us some guide. Whether mother titer is also 1 in 8, baby is 1 in 2. So baby is considered still much lower, but it's not being done at the same time. So as far as possible, on the safe side, we still prefer that both mother and RPR titer be done adequately. So if the mother titer is really confirmed only 1 in 8 or lower, and baby is only 1 in 2, then we are quite certain this baby are not infected. All right, I think I got time for another case. Okay, this case number 2 is a baby born at 36 weeks or so, and the same year in 2016. Baby a bit, I think this baby is a late premature with a bit of SGA, 2 kilo. But he's clinically well and no symptoms. Okay, and again, this baby have a very low RPR titer, 1 in 2 at birth. From the maternal history, she's a 33 years old. She got 1 abortion in the past, and could be her first baby. And fortunately, her HIV is negative, but her RPR is positive. But by the time the baby referred to us, we actually don't know what's the mother RPR titer at that times. We only have the latest results stated 1 in 2 at about again another about 2 weeks before the baby was born. Mother is 1 in 2, and the mother TTPA is reactive. And both parents were treated. They have complete 3 doses of iron penicillin on more than about 2 months before the baby was born. But unfortunately, father without RPR status is not known. So again, does the mother have syphilis? Yes, I think we know that mother have TPH positive and her titer is positive, RPR titer. But unfortunately, we don't have mother serial titer. So a bit difficult for us to judge whether mother was her syphilis was adequately treated. But if you assume the mother is treated with appropriate penicillin regime, then it will happen about more than 2 months before the delivery. Let me go back to the first slide. Okay. So as you can see, the mother was treated 3 doses before 3 months, and we only know her latest result is 1 in 2, 1 in 2, and the baby delivery time also 1 in 2. But unfortunately, we don't have the serial titer or mothers, and again, this mother, the RPR was not repeated on the way. How about risk of infections? That's possible because father also treated. I'm sure the father is infected because otherwise they won't treat the fathers. But unfortunately, we don't know what's the father titers. So this is a bit challenging for us. But I think at the end, we judging from the mother treatment, some of the treatment history we documented treatment by the local health staff, and even though we don't know her serial titer, and the baby titer was very low at 1 in 2 and baby well, we finally, and this mother, we quite certain that they will not default or follow up. So finally, the managing team actually decide we do not treat the baby. And I think eventually the baby was under a follow-up, and his RPR was eventually become negative. So this again, this baby is not a conjunctivitis. Okay, we come to the last case. I still have some time. This is probably a little bit complicated. This case, this baby was born SGA 2.3 kilo on the same year in September. He's well and no other abnormality except noted to have hepatosplenomegaly. So he got the liver, spleen. I can't remember the size, but not very big. This was a case referred by one of the district hospital in one of the northern state. And they informed me the baby RPR was quite high that time. It was 1 in 64. And the mother is a 24 years old primary gravida. She's unmarried. She claimed only had one sexual partner. And but baby biological father RPR status is not known to us. So she did a late booking at 32 weeks. Her RPR, mother RPR was 1 in 16 at the time. So mother started on treatment on IM benzathine penicillin on 2nd of August, but unfortunately she defaulted after the second dose. So this case, definite mother are not adequately treated, not adequately treated. So mother RPR was repeated at delivery, remained quite high in 1 in 16. So despite that, because of the history of default and not treated, so the local pediatrician decide to give the treatment of baby, and they decide to give 2 weeks of IV Zipan at 100,000 units per kilo per day, divided into 2 doses. And they did blood CNS, no growth. The caretaker refused lumbar puncture, unfortunately. I don't know whether the mother or the electrical they refused us to the local team to proceed with spinal fluid examinations. So on follow-up at 1 month of age, the RPR titer even go higher. I think you remember in previous slide, the baby born at time is same, it's 1 in 64. So after 2 weeks despite 2 weeks of treatment with IV penicillin, the baby titer doesn't come down after 1 month, remains quite, I think any one of us, if you see the baby at 1 month old with the titer of 1 in 64, I think we feel very uncomfortable. And remember the mother RPR at the rate only 1 in 16. So if you look at this, despite that, it's very higher, 4 kali ganda, 4 times higher than mother titers. So what happened in this case? What do you think the mistake here? And also, I shouldn't call mistake. Any shortfall here? What's the main shortfall? I think some of you may have a sharp eye. You noted something there. What's your noted? Look at this. Baby was given 2 weeks IV penicillin, 100,000 units per kilogram, divide into 2 doses. Is it correct dosage or not? Yeah, it's not. You remember the dosage I have told you, by after 7 days of life, the dosage should go higher at TDS dose instead of PD dose. And unfortunately, this case, however, we did not have this LP done. And you remember I told you cases of CNS syphilis, you have to repeat the LP eventually on follow-up. So I think the local, after they consult me this case, actually they managed to persuade the mother and to get the baby admitted, and they managed to get an LP done. But I think this child very unfortunate. She need after the second course of appropriate dose of penicillin given to this baby, the second course after the discharge, when they follow up the child again in 1 or 2 months, the serology remain higher. I think this child end up have 3 courses of treatment. All 3 courses we need to proceed with 2 weeks of IV penicillin for her. Then only finally we managed to clear out the infection from baby. This case actually basically illustrates this is the thought. This case, as you know, from beginning, mother had a lot of social issue. She default. She have, we don't know her partner. We couldn't trace her partner. No, her treatment is not adequate. Most probably she got the syphilis very early because it's an early stage of syphilis because this is a primary gravida mothers. She probably just acquired infection with the current partners. So I think this highlights some of the important points that you need to take care when you deal with this kind of cases. All right. Okay. With that, I hope you benefit from the talk today. Okay. Maybe then we can go to any Q&A session after this.
Okay, thank you, Dr. Chu, for your very thorough presentation together with very useful case scenarios. So we go to question, yeah, Doctor?
Yeah, sure.
So the first question is from Wenjing. What are the medications that baby born with congenital syphilis with bone changes noted on X-ray and high ALP be on? Will it be sufficient to give vitamin D treatment dose and oral phosphate to the baby?
I didn't quite get. You mean this baby, I assume, is born to a maternal syphilis mother, all right? Can I assume that it's a maternal syphilis mother, or this is any baby that without history of maternal syphilis?
With you can assume as a maternal syphilis mother, Dr. Chu.
If the mother to have maternal syphilis, then we have to come back to the point that I mentioned. You have to ask: is the mother really treated? No. If she have confirmed maternal syphilis, was mother adequately treated? If the mother is very adequate treated, and we are very sure the mother titer is coming down, the risk of infection to the baby is very low, then a bit unusual. The baby just manifests some bone. You say got some bone changes, and what else they say? Other than the bone changes, long bone changes, what else? What other features we have for this baby? Sorry? Yeah.
Sorry,
But
if
other
you
than
can
bone changes, what other features we have this on baby?
high
It's just bone
ALP,
changes alone.
that's all from the question that they
If
give.
bone changes alone, if the mother has been adequately treated, I don't think we can assume it's always syphilis, kind of, right? Of course, I wouldn't say it's possible syphilis. I think we need to assess back the baby titers, baby. In this case, maybe I will still do a TPH on baby, especially when have concern like that. Of course, I need to screen thoroughly the baby for other features of syphilis as well. If because you might get bone changes due to other causes other than syphilis. Okay, if let's say there's no other features of syphilis, then we have to ask ourselves, or we have to refer this case to a neonatologist to further work out whether these bone changes could be due to other cause like vitamin D deficiency or some congenital vitamin D deficiency or some endocrine problems for these osteopenic changes in the bone. So I think the bone changes alone is not, unless the bone changes is very drastic, and we need to look at the X-ray, and we got the X-ray expert opinion. This is typical of syphilis, polyotitis, or this otitis. But I don't think the bone changes is very characteristic only happen in syphilis. You can have similar changes happen in other infections as well. So I think again, I don't think I can give a direct answer like whether it's yes or no. We need to know. We need more data to confirm this baby has syphilis and decide to treat him or syphilis or not. Of course, as I say, if we are not certain, if we are really in doubt, and then of course, I think no harm that we treat the baby as syphilis to be on the safe side. Yeah.
Doctor, if bone changes with high ALP, it
Oh,
will.
you're talking about this is different from this. You mean a neonatal? Oh, I see. This is a neonatal problem. This is a neonatal and metabolic changes. Of course, if you suspect the baby might have vitamin D or hyperphosphate, or you think this is rickets or prematurity, of course, you need to start vitamin Ds and also given calcium supplement and phosphate supplement this baby. I think this is not this is an answer that I'm not the expert to give. We should ask the neonatologist to answer. This question whether to give phosphate, but phosphate is not a treatment for congestive syphilis per se. All right, answer that, yeah.
Yeah, okay, Dr. Chu, thank you very much. For any other questions, we will bring it to Dr. Chu, and he will answer it and email back to all of you all. So thank you so much, Dr. Chu, for your time and commitment. So we shall go to the next speaker, Dr. Chu. Thank you very much.
I think I need to stop sharing, right?
Yes, yes, doctor. Just go up at the orange panel at up there on the top.
Orange panel at the top. Orange panel. I don't know why I can't close this window. Need to stop sharing.
On the top, there's an orange panel. You just slide your mouse there, and the stop share button will show up.
Okay. Okay, is it stopping?
Yes, doctor. Yes. I will proceed with the next next presenter, doctor. Yeah.
Yeah. Okay,
Thank you. Thank you very much. Okay, I hope everyone is doing well at the moment since we are getting a lot of very valuable information today. Okay, let's go straight to our fourth speaker today. Our fourth speaker is Dr. Rosanani binti Muhammad Zain. Currently, she works as a clinical virologist since 2010, and until now, Dr. Rosanani is currently the consultant clinical virologist working at the Virology Unit, Infectious Disease Research Center. She supervises all specialized viral diagnostic testing or activities that are carried out in the unit to support the lab testing for most government hospitals and primary health care facilities in the country. As a clinical virologist, she is actively involved with the National Reference Laboratories activities and the designated reference laboratories. National Poliovirus Lab Laboratory, WHO National Influenza Center, National Reference Laboratory for HIV or AIDS, and a National Laboratory for viral hepatitis, and recently designated and National Laboratory for Japanese encephalitis until 2015. In line with the Ministry of Health strategic policy priorities, Dr. Ruzani had taken up the challenge to lead an important project in developing and implementing HIV drug-resistant genotyping assay for the country. The test was initially started as a 2-year research project and thereafter successfully expanded as a diagnostic test. Currently, the test has been made available nationwide throughout all government and private hospitals across the country. Information obtained from this test can be used to develop HIV drug resistance database for the country as well as enhancing the national policy and practices in managing HIV patients in Malaysia. She also responsible in carrying out National External Quality Assurance Scheme and EQAS to detect the presence of HIV antibodies and to access other government and private laboratories in the country in performing the tests to detect the IV antibodies. NEQAS has substantially expanded to many hospitals and primary health care facilities. Recently, a new scheme on hepatitis serology external quality assurance scheme was introduced by AMR and carried out and sample panels were sent to all major state hospitals in Malaysia. Furthermore, she is involved with all activities related to polio eradication program and severe acute respiratory infection surveillance. She is an active member of ISO 15189 Implementation Committee for IMR. Dr. Razanani has actively involved in conducting research. She has been involved with research in many medically important viruses such as HIV, hepatitis virus, Middle East Respiratory Syndrome coronavirus, MERS-CoV, dengue, Zika, rubella virus, and SARS-CoV-2. Okay, I'm already out of my breath. Okay, so I present Dr. Rosanini for our next topic, which is the updates on screening and diagnostic testing of HIV, adults and pediatrics, ensuring quality in HIV diagnostic. Dr. Rosanini, you may proceed.
Thank you very much, Dr. Iza, for the kind words. Assalamualaikum and good afternoon all. First of all, I would like to thank the organizing committee for the invitation to speak in this webinar. And the topic that was given to me is the updates on the screening and diagnostic testing of HIV, adults and pediatric, ensuring quality in HIV diagnostics. So this is the presentation outline. So first of all, I will talk about briefly on the introduction. Then we go straight on to the updated HIV testing algorithms. First on the rapid diagnostic test. Second on the adult and children 18 months and above. And third is on the pediatric population. And the next section will be, I will be talking on ensuring quality in HIV diagnostics and as well as the conclusion. Okay, I think hopefully everyone can see the slide now.
Yes, we can see, Doctor.
Okay, thank you very much. So as I mentioned, this is the presentation outline for
Doctor, sorry, Doctor, can you full screen first? Full screen. Okay. All right, thank you.
Thank you. So basically, this is the presentation outline for my talk. Briefly, I will be talking on introduction, and then we go straight on to the updated HIV testing algorithms for these three categories, and then we will see on how to ensure quality in HIV diagnostics, and briefly on the conclusion. So basically, just a quick one. This is a global HIV statistics for 2020. Yeah? If you look at here, there were about 37.7 million people globally were living with HIV. And out of these, 36 million were adults and 1.7 million were children aged 0 to 14 years. And 50% of all people living with HIV were women and girls. And if we look at the total number of people who had accessed antiretroviral therapy, there were about 27.5 million people in 2020 that had access to the antiviral therapy. And then 73% of all people living with HIV were accessing treatment. And 74% of adults aged 15 years and older living with HIV access to treatment, and only 54% of children aged 0 to 14 years had access to the treatment. And then another important point here is that 85% of pregnant women living with HIV had access to antiretroviral medicines to prevent transmission of HIV to their child. So again, if you look at the new HIV infections, it had reduced by 52% since the peak in 1997. And if you look at we had about 1.5 million people with newly infected HIV as compared to 3 million before. And then if you look at women and girls have accounted for 50% of all new infections. And if we compare the data between 2010 and 2020, there is a decline. A new infection has declined by 31% from 2.1 million to 1.5 million in 2020. And then if you look at for children, since 2010, new HIV infections among children have also declined by 52% from 320,000 in 2010 to 150,000 in 2020. So just a quick one on the epidemic snapshot in Malaysia for 2020. I think maybe speakers have touched on this. Basically, for the new infection, we had 3,146 in 2020, with estimated about 92,063 people living with HIV, and then with the ART coverage 58.3% on the treatment. And then we reported about 45,450 AIDS-related deaths. So if we quickly look at the global AIDS response indicator for Malaysia, look at the commitment number 2, which is to eliminate new HIV infections among children by 2020 while ensuring that 1.6 million children have access to HIV treatment by 2018. So if you look at for the 2020 data for early infant diagnosis, we had 100% coverage. And then for mother-to-child transmission of HIV for 2020, the percentage was about 1.69. And for preventing the mother-to-child transmission of HIV, the rate was 99.1% for 2020. So WHO has released a few guidelines before, but with the new evidence and recommendations, WHO released another guideline in 2019, where this time around WHO has updated recommendation on the HIV testing services and provides new recommendations on social network-based HIV testing approaches and Western blotting. So basically, in this guideline, the Western blot is not recommended to be used in the national testing algorithm. And then at the same time, WHO has recommended HIV testing algorithm to achieve 99% positive predictive value and to use tests with at least 99% sensitivity and at least 98% specificity. And then WHO also has recommended to use a highly sensitive test for the first test and a more specific test for the subsequent test for the HIV diagnosis. I'm trying to move my slide. It's not moving. Just give me 1 second. Okay, it can move now. So basically, with the new guidelines from the WHO, we thought that it would be good to update our HIV testing algorithm as well. So we had a series of meetings in 2019 where Aymar was appointed as the secretariat. So basically, we had invited experts from various places, yeah, to be part in this discussion in updating the HIV testing algorithm. So we had invited a few clinical microbiologists from the state hospitals, and then we also invited experts from the private laboratories as well as from the universities, and we also had representatives from family medicine specialists as well as ID physicians, and then also we had a representative from HIV/AIDS sector as well. So with all the discussion that we have done, we finally managed to release the HIV testing guideline on 4th December 2020. I think it's a bit delayed. There was a delay in publishing this guideline. Most like, I think everybody knows it's due to the COVID-19 pandemic. But the most important of all is that we managed to release the guideline by end of last year. So now we're gonna quickly look at the HIV testing algorithm. So I will first touch on the rapid diagnostic test, and second is HIV antigen antibody combination assay for adult and children above 18 months, and the third one is HIV PCR for pediatric population less than 18 months. So if we look at our first guideline on the rapid diagnostic test, this is a simple test to do. Again, if you look at here, we need to record the test, whether it's reactive or non-reactive. We go to the right arm first. If the test is non-reactive, then we need to report it as anti-HIV rapid test non-reactive. But again here, if you look at, we require some other informations to be recorded as well, such as name of the rapid test kit, date of test, testing site, the operator, the kit lot number, batch number, as well as the expiry date. So this is important just in case later on we'll be facing some issues with the test result, then we might want to go back to look at all these details, and so that the problem can be rectified easier. Yeah. And then if you look at the left arm of this testing algorithm, if it's reactive, then we need to report as anti-HIV rapid test reactive. And again, all this information is required, as you can see here, required to be documented. Yeah, and then we need to send the sample with a positive sample to the nearest hospital for further confirmation or further testing. But again, I would like to draw the attention with the non-reactive group. Yeah. With those with the non-reactive results, because for those with ongoing risk, it is required to do retesting after 4 to 6 weeks. Yeah, and then the groups that we need to consider, as I have listed here in this presentation. So basically, among the groups are to include people from key populations, people with a known HIV positive partners, yeah, people with non-recent HIV exposure, individuals seen for a diagnosis of treatment of STIs, the TB patient with a possible recent HIV exposure, and so on. So the next algorithm that we'll be discussing is on the algorithm for laboratory HIV testing using HIV antigen antibody combination immunoassay for adult and pediatric age group more than 18 months. So basically, if you can see here, the first test that we do here is basically enzyme immunoassay. As many would have known, now I think most of the labs in Malaysia are using 4th generation AIA, where the presence of antigen and antibody can be detected simultaneously. And then with the use of 4th generation AIA, I think detection of the HIV infection can be expedited to 2 weeks post-infection, as compared to if we use only the 3rd generation, where we can detect the presence of HIV antibodies 3 to 4 weeks after the infection. Yeah, if you look at the left arm first, if it's reactive, yeah, then we need to proceed with a supplementary test, which is either particle agglutination or HIV1 and or to differentiation assay. At the moment, most of our labs in Malaysia are still using a particle agglutination for the supplementary test. So once it is reactive, EIA reactive supplementary test detected, then we can report it as a HIV1/2 positive. Yeah. So again here, if the test, if this is the first sample, then we might want to ask for another repeat sample to confirm, to verify the positive result, or if it's second, then we take it as a confirmed result. And then at the same time, we can recommend to go for the HIV RNA PCR. But what happens if the EIA reactive, but the supplementary test not detected or indeterminate? So we have to report it as HIV1 or 2 inconclusive. And at this time, we require new samples. First, we require samples in clean tube for EIA, enzyme monoassay, and at the same time, we require HIV EDTA tube, EDTA blood for the HIV RNA PCR. Then once we have received those samples, we're gonna proceed with the same test, EIA and supplementary test. So again, if it's reactive for both, reactive for EIA and supplementary test detected, then we report it as HIV1 or 2 positive. But again, if we repeat the test, but the results are still the same, then we're going to proceed with the HIV RNA PCR. Then if it's positive or detected, then we have to report it as HIV positive. And if it's not detected, then we report it as a HIV negative. Yeah. If you look at the other arm on the right-hand side, if it's when we run HIV antigen antibody EIA, and the result is non-reactive, then normally we will support with a supplementary test, a particle agglutination test, and then we report it as HIV1 or 2 negative. But again, for the non-reactive results, you have to bear in mind, if there is a possibility of very early infection leading to a non-reactive results, then it would be good to have another sample tested after 2 to 4 weeks later. Okay? So this is the new HIV algorithm using for the adults as well as pediatric age 18 months and above. So this is the algorithm for diagnosis of HIV infection for pediatric age group less than 18 months. So basically for pediatric age group less than 18 months, we do not do serology tests. For the diagnosis of HIV, we will proceed with HIV1 PCR. So basically what we do here, there are 2 groups of babies, I would say. The first group is basically babies born to mother living with HIV, and the other one, babies born to the mother which HIV status is unknown. So for the mother, HIV status is unknown. What we need to do is basically to screen the baby's blood for the serology first, and if it's reactive, then we need to proceed with the HIV RNA PCR. But if it's not reactive, then that's it. We don't have to proceed any further unless there is some other indications. Yeah. So if you look at here, overall, we need at least three tests, 3 PCR tests. The first one, it can be done at the age of 0 to 14 days of age. Then if it's positive, then we need to request for another sample to confirm the positivity of the test. And then if it's negative, then we need to repeat the test at the age of 4 to 6 weeks. Yeah. And then if it's positive again, we need to request a fresh blood sample as soon as possible to verify the results. And then if it's negative, then we repeat another test, HIV1 RNA PCR at the age of 3 months and above. And then if it's negative, then we can conclude as negative HIV1 RNA. So when exactly we have to do the repeat for the serology test for the pediatric population, we recommend to do it at the age of 18 months, yeah, and then or 3 months after cessation of breastfeeding, whichever comes later. I think there's some issue with the breastfeeding that we have discussed so far. Okay, if it's non-reactive, then we say is negative for HIV. So to confirm HIV test, confirming HIV test results in infant. So basically, as I have mentioned, we need at least 2 HIV, 1 RNA-PCR test result to be negative to be sure that the baby is not infected with HIV. And again, even for positive results, also we need at least to have 2 results of HIV RNA positive to know for certain that the baby is infected with HIV. And for infant less than 18 months of age with HIV, mother living with HIV, where the test is missed by the recommended age, HIV-1 RNA-PCR test need to be done as soon as possible. So I think that's the 3 HIV testing algorithms that we will see that we have discussed. So I'm going to move to the next slide, but the slide is stuck at the moment. Maybe we have to wait a bit. It's still not moving. So just bear with me a bit longer. Okay, good. Okay, the next component is basically to ensure quality of the laboratory services. So as we know that accurate, reliable, and timeliness of laboratory test results are essential for diagnosis, treatment, and monitoring of diseases. So laboratory quality system is mandatory to be implemented in the laboratory facilities as a tool for assuring quality of laboratory services. So basically, I think most of the labs in Malaysia are ISO 15189 certified. Yeah. So basically, with this ISO, the lab shall participate in laboratory comparison programs such as external quality assessment program or any proficiency testing programs. And then the labs also should involve with the implementation of corrective actions when any predetermined performance criteria are not fulfilled. So basically, now we can use other alternatives to ensure the quality of the laboratory services, and these alternatives are to include we can use certified reference material or previous examined samples, materials from cells or tissue repositories, exchange of samples with other laboratories, and also we can use control materials. So basically, IMAR has started a National External Quality Assurance Scheme or NICAS for anti-HIV screening. We started the biannual assurance program in 2000, where we have provided each panel consisted of 5 serum samples to the participating laboratories. So basically, this National External Quality Assurance Scheme is designed as a tool for participating laboratories to monitor their laboratory performance, as well as to improve and strengthen laboratory capacity for good quality service of anti-HIV testing. So basically, the result that we have obtained, we analyzed for test accuracy as well as turnaround time for releasing a test report. So if you look at here, this is a number of the laboratories that have participated in the National External Quality Assurance Scheme, IMR. So basically, from 2006 to 2016, we had like about 50 to 60 labs that had involved with this National External Quality Assurance Scheme. But since 2017, where Klinik Kesihatan had started to join as part of the requirement for the PMTCT program. So we can see this increase in the number of the laboratory participation in our external quality assurance program. So for IMR, because we are the only centers who's running for the HIV-1 RNA PCR qualitative for the pediatric population, we had implemented inter-laboratory comparison with the HKL, yeah, because there is no specific external quality assurance program for the HIV-1 PCR qualitative national and internationally, yeah. So basically, HKL has provided us about 10 samples for us to evaluate, and then it is provided once or twice a year. So how do we ensure the test result from the rapid diagnostic test? As we know, in Malaysia, HIV rapid diagnostic tests for the primary care laboratories are procured centrally by the MOH, and then the kits are distributed to the respective labs to be supplied. Distributed to the respective states to be supplied to the relevant clinics. Yeah. So basically, we have put the requirement for the kits to be at least 99% sensitive and at least 98% specific. Yeah. And each year, these rapid diagnostic tests are sent by 4 consignments. And with each consignment, the test will be tested and evaluated for its performance. So another important area that we need to look at when it comes to ensure the quality of the laboratory services is staff competency or training. Yeah, for IMR, we have prepared the laboratory quality procedure, what we call our QP for the personnel management. Yeah, so the objective of this manual is basically to ensure IMR laboratory personnel are managed according to the requirements of laboratory quality management system. And the scope is basically for the management of personnel involved in the medical laboratory testing in IMR. So basically with this quality procedure, we should be able to identify qualified personnel. We need to have the orientation of any new personnel that come and join us in the lab. And then we also need to provide personnel training as well as to provide, we need to do competency assessment. And for the competency assessment, normally we do it 2 yearly. This is important to assess whether the staff is really competent in completing the job that has been required by them. Yeah. So the next one is basically, this will be my last slide here, the laboratory data management. So for the hospitals, I know they have the laboratory information system or LIS. For IMR, we have successfully developed what we call specimen management information system, or short form is SMIS. Yeah. So this is to ensure whatever results all results that received by the requester are in a timely manner according to the stipulated turnaround time. And at the same time, this is also to prevent loss of results as the results are available in the server for 3 months. Because I think previously we had too many complaints on the loss of results, the results did not available for the patients and so on. So I think this is a good way of managing our laboratory data. So in conclusion, effective HIV testing strategies and algorithms act as one of the vital elements of the national HIV response, essential to achieving and maintaining low HIV incidence. And we know that accuracy and reliability of diagnostic or laboratory testing will be critical to the success of the HIV/AIDS programs. I think that's all the slide. Thank you.
Okay, thank you, Dr. Rozanani, for your excellent presentation. It seems that we have a few questions here for you. Are you okay to answer it? Can you can have a look at the chat box on the right down side as well if you want to have a look at the question. So the question number 1 is, I have 2 patients with high risk bisexual activities. Rapid test positive repeatedly, but confirmation test negative persistently. But only ECLIA confirmation was done. No PA-LIA WB done in spite of adequate history given. The footnote mentions that PA would not be done if ECLIA is negative. Can we be sure to let the client know that they are HIV negative and can safely be started on PrEP medications? One of these patients even did CD4 and it was only 326 viral load, but viral load was not detected. How to explain these inconsistent results?
Thank you very much for the question. I think the question is long. So to my knowledge, yeah, sometimes it's not easy to make a diagnosis of HIV. Some of the cases are quite straightforward, but many are not. So basically, we have seen quite a number of patients which is not really the results as not what we have expected. Yeah. So basically, as you can see here, these patients has a high risk, yeah, ongoing risk. So I would think that the test need to be done regularly based on the risk, and sometimes you need to monitor the results of all the tests that you have done before you can conclude the status of the patient. But I would say it would be good also to go for the HIV-1 PCR qualitatively, because sometimes I think the test is more sensitive as compared to the viral load. But again, we need to look at the different platform of the test itself, because different tests have a different lower limit of detection. So that may play some roles as well.
Okay, doctor. Question number 2 from Josephine Tang. May I know any conditions or causes which may cause false positive results in HIV, ECLIA or Western blots, etc.?
Okay. Based on our experience, yeah, Josephine Tang, we find it those with immunological diseases, they could have contributed to their false positive results for the Western blot, because we can see P24 line there whenever we tested with sample from patients with immunological diseases. So it would be good to get some background history on what sort of disease that the patient is also suffering from. So I think it will, at least you can know what to expect from your test results.
All right. Thank you, doctor. For the last question is question 3 from Dr. Anissa Diana. The question is, if HIV-1 RNA PCR not detected, can we conclude that HIV-2 is negative as well?
Okay, this is interesting part. I did not say anything at all on the HIV-2 test. Yeah. At the moment, at IMAR, we do have test for the HIV-2, and then we do also have HIV-2 PCR. So again, I would look at the clinical history of the patient, whether we have to go on to proceed with the HIV-2 PCR or not, because the test is an in-house test. Because a moment we say that we're gonna offer to all, then I'm afraid that it will be test that just to rule out some infection, which is HIV-2. So if you really have a good indication why HIV-2 need to be HIV-2 test need to be done, then please describe properly in your request form, or I think this test is you need to consult us first before you can send the test to us.
Okay, doctor. Thank you. So there's a few questions on the chat box as well. How common HIV-2 is in Malaysia, and how do you test to differentiate from HIV-1?
Okay, how common HIV-2 in Malaysia? So far, we haven't had any HIV-2 in Malaysia based on our studies previously. when we run our Western blot for HIV-2 last time, there's some cross reactivity of the antibodies between HIV-1 and HIV-2. So when we proceed with the HIV-2 PCR, it was negative. So I would confidently say at the moment we don't have any HIV-2 in Malaysia. But let's say we have a positive HIV-2, the next step for us is to proceed with the sequencing. This is to confirm that the HIV-2 is really there, is really present in our country. So how do you test to differentiate? So basically we have a separate PCR-assay, which is specific for HIV-2, where we use a specific primers and probes to detect HIV-2. It is totally different from HIV-1.
Okay, doctor. So the next question is from Aini. Just want to ask, let's say EIA positive but PA negative. Do we need to wait for 4 weeks to repeat the sample, or we can repeat immediately?
Okay, I think this one, my personal opinion is that we should give some times, before we can repeat, because this is to ensure that whatever result that we get later on is something valid that we can use to further advise the patient. So normally we recommend at least 1 month to repeat the test. I think it depends. If the case is required to be confirmed or to be confirmed immediately, then we would ask for a repeat sample immediately. But if we think that you might want to wait for another 4 weeks, also there are cases that we ask them to send after a few weeks. Yeah.
Okay, thank you, Dr. Rosanani. I think that's all that we can ask for you today, because due to limited time. So thank you for your commitment, your time, and also for having us, for coming and joining our webinar today. So thank you, Dr. Rosanani. We shall proceed with our next speaker. Yeah. So let's move on to our last topic of the day. Is everyone okay? Our last topic is updates on screening and diagnostic testing of syphilis, the role of rapid diagnostic test RDT in antenatal screening. The topic will be given by Dr. Noraini binti Ismail. Dr. Noraini is a consultant pathologist in medical microbiology. She currently works at Hospital Sultanah Bahiyah, Alostar. And regarding her education, she completed her undergraduate studies in UKM in 1989 and obtained her master in pathology in medical microbiology at USM in 2003. She has been the head of the National Microbiology Services since 2020. Okay, Dr. Noraini, dipersilakan.
Terima kasih Dr. Izzah. Assalamualaikum dan selamat tengah hari untuk semua ahli jawatan kuasa, penceramah dan juga peserta webinar kita pada hari ini. Sekarang dah 12.45. Saya harap semua peserta masih bersabar. Pemandangan ini adalah last talk yang telah diberikan kepada saya dan dengan tajuk opening screening and diagnostic testing of syphilis, role of RDT in antenatal screening. Sebenarnya ini dah jadi macam revision lah, because most of apa yang saya akan bentangkan juga telah disentuh oleh dua penceramah yang terdahulu Dr. Nik Mazlina and also Dr. Chu. Dr. Chu pun dah seru nama saya banyak kali tadi, dan kebanyakan yang pertinent things that saya nak bagi tahu juga telah disebutlah sebenarnya oleh Dr. Chu. As an introduction, kita semua telah tahu treponema pallidum yang menyebabkan syphilis, dan ada satu yang penting kita tahu, treponema pallidum ni dia ada banyak spesies boleh menyebabkan penyakit-penyakit lain seperti yos, pinta. Jadi ini akan ada implikasi bila kita test dalam pengujian untuk syphilis. It is a spirochete bacteria, difficult to culture and see under the light microscope. Jadinya The laboratory diagnosis rely mainly on serology testing. And when we discuss about serology testing, it involves both non-treponemal test and treponemal test. Tak boleh buat satu, we need both. And at present kita tak ada satu lagi gold standard, ya, satu gold standard yang digunakan untuk diagnosis syphilis. Okay, we go to non-treponemal. Saya rasa semua orang familiar with VDRL. Kita sebut VDRL tu sebenarnya VDRL tu adalah Venereal Disease Research Laboratory. So VDRL test ni diambil daripada perkataan ni, and also RPR, Rapid Plasma Reagent Test, ya. These are the two non-treponemal test yang kita lakukan. Seperti yang Dr. Chu dah mention, sebenarnya kita tak guna dah. Most of the hospitals are not using VDRL anymore. Ya, nanti saya bagi tahu sebab apa. Test non-treponemal test, dia detect antibody towards reagent. Reagent ni adalah combination of cardiolipin, lecithin and cholesterol, which is generated from interaction of the host with treponema pallidum. So dia tak begitu spesifik, ya. Dia tak spesifik to treponema pallidum infection, but it's cheap, easy to perform, fast. And saya tuliskan dalam merah tu sometimes because in certain KKs it will be done in batches. Selalunya kita KK akan makma di KK akan tunggu sehingga petang, ya, akan buat dalam satu batch, ataupun dalam setengah-setengah KK because of the workload dan sebagainya akan dibuat dalam masa 2-3 hari, ya. So ini adalah proses-proses yang mungkin menyebabkan terdapat kelewatan dalam laboratory mendapatkan diagnosis, ya, untuk jangkitan syphilis. Okay. This non-treponemal titers correlate with disease activity. Ya, kita gunakan untuk tengok activity of the diseases, tak seperti treponemal diseases. And we used to follow treatment response. Selalunya the titer will decline with time after treatment. Dalam masa setahun, ya, dalam masa 4 bulan usually the titer will reduce 4-fold, and 8 bulan it will reduce 8-fold, and by 1 year dalam early syphilis ia akan menjadi negatif ataupun akan serofast. Okay. Dan yang pentingnya untuk kita kata there is a significant difference, kita nak ambil itu different, itu ada significant, kita kena tengok kepada fourfold change in titer, ataupun kita sebut change of two dilutions, ya. Sebab maknanya daripada 1:16 kepada 1:4, ataupun daripada 1:8 meningkat kepada 1:32. So yang bila terdapat peningkatan fourfold change ataupun change of two dilutions, baru kita kata that there is a significant decline ataupun significant increase. Okay. And I think Dr. mentioned juga, repeated testing on same patient should be performed using same test and preferably by the same laboratory. Itu belum lagi same person. Dulu kita ada cadang juga, boleh tak orang yang sama buat dia. Sebab saya rasa bila saya present masa during morbidity, mortality mesyuarat, kita kadang ada selalu sebelum ni saya selalu dapat pertanyaan kenapa sekejap naik sekejap turun, ya. Cuma kita kata kalau 1-fold tu kalau naik 1 saja bukan double, so it is still acceptable. Nanti saya tunjuk kenapa, macam mana test itu dilakukan. So bagaimana kita nak tengok supaya kadang-kadang dia terdapat perbezaan dari segi orang yang melihat. Jadi sepatutnya kalau kita nak repeat on same patient, kita buat dalam lab yang sama lah. Kita tak boleh guna lab results pada KK kat Langkawi ke, lepas tu hantar pula ke hospital sudah bayar, lepas tu kita nak compare, ya. Sepatutnya dia kena buat di lab sendirilah, baru kita boleh tengok, because kita menggunakan orang yang tengok pada awalnya, ya. Dan RPR test, the titer from RPR test cannot be compared with VDRL directly, sebab telah diketahui RPR titer ni adalah sedikit lebih daripada VDR titer. Tapi sekarang macam yang kita katalah, sebenarnya most of the hospital sekarang ni memang dah tak gunakan VDRL. Okay. Semalam ada pertanyaan apa beza RPR dengan VDRL test, ya. Dua-dua menggunakan flocculation assay, maknanya flocculation tu dia akan menyebabkan berlaku clumps, ya. Clumps. Tapi kalau kita tengok for VDRL, it is a micro flocculation, and for RPR it is a macro flocculation. Jadi sebelum ni memang VDRL kita kena tengok menggunakan mikroskop. Tapi tahulah dekat lab sekarang kadang nak dapatkan mikroskop pun susah, dan macam susah sikit lah kita nak buat test. So in RPR test, dia dah addkan charcoal dalam tu, di mana kita boleh melihat flocculations atau clumps tu dengan mata kasar, ya, dengan mata kasar, tidak memerlukan mikroskop. So most of the labs have already changed from VDRL to RPR. Tapi cuma kadang bila kita dah biasa kan, kita sudah okay VDRL test. Sebenarnya yang dibuat tu adalah RPR. So you maybe the doctors kena check dengan with your lab, tengok sebenarnya test apa yang dibuat. Sebab saya tahu kadang ada lagi walaupun dah buat RPR test tu, saya takut juga ada yang dia tak tukarkan the test apa yang dia buat. In fact, kalau kita dapat sekarang pun masih lagi request tu banyak VDRL, ya. So sebenarnya check with your lab, tengok adakah, saya rasa tak ada dah. So sekarang we are moving actually to RPR test, okay. So saya rasa itu menjawab satu soalan yang ditanya semalam lah, apa perbezaan RPR dan VDRL. So this is how the test looks like lah, ya. I hope you boleh appreciate, for every test that we do in the lab, we need to have a control. I think Dr. Zainani pun tekankan mengenai quality control. So ini adalah positive control. You can see, saya harap you boleh nampak lah ada benda hitam-hitam tu kan, itu adalah clumps, ya. And then this is a reactive. Kalau non-reactive, we don't see that clumps. Yang ni ada sikit-sikit, which is minimal to moderate reactive. So kalau kita tengok the next one ni, maknanya ada yang ni adalah ni, this is the positive test, okay. Selepas positif, kita akan melakukan dilution pula, ya, daripada test yang bila once positif, kita akan melakukan dilution 1 in 1, 1 in 2, 1 in 4 sehingga dia setakat mana dia akan meningkat lah, actually by 1 in 5.2, ya. So boleh ke nampak, ya, nampak sikit-sikit kot, ya, nampak sikit-sikit. Okay. So this is how the test looks like, ya. Jadi sebenarnya kalau nak kata perbezaan satu tu dia mungkin tak berapa ketara. So usually kita ambil untuk nampak tu is double ni lah, dia perlu fourth meningkat double ataupun fourfold. Okay. So this test seperti yang kita kata tadi, dia adalah not specific to non-treponemal, ya. Dia cuma adalah untuk jadi dia ada banyak false positive results yang boleh disebabkan oleh infectious causes seperti malaria, tuberculosis and viral fevers, and also in non-infectious causes, ya, drug addiction, connective tissue disease, pregnancy sendiri, ya. Cuma the titer tu lower, ya. Kita pun ambil kalau positive is 1 in each, and all positive non-treponemal test need to be confirmed using treponemal test. Kita tak boleh guna satu saja, ya. Bila kita guna satu, dia akan boleh menyebabkan false positive, ya, false positive, dan also false positive in patients who does not have syphilis, and also false negative, especially in early during primary syphilis, during early syphilis. Okay, next tadi kita dah cakap pasal non-treponema test. The other type is the treponema test. Yang ni adalah dia detect antibodies specific to treponema species. Bila saya cakap treponema species tadi saya dah mention dia ada beberapa non-viral trypanosomes ya, seperti yours, yang tu ada. So selalu masa dulu kita kadang-kadang dah tahu orang tua yang lama-lama kita look whether dia, sebab kalau kat Malaysia ni yang kita boleh tengok adalah yours lah. So it can cause positive TPPA, and for treponema test, one is positive, it remain positive for life if that patient has previously had syphilis. And one thing about treponema test, dia tak boleh differentiate between previous or current infection. Ya, dia tak boleh kata. So you want to have, nak tengok the activity, we need to do the RPR test. Okay, these are the list of treponema test yang ada, yang biasa dan ada yang pernah digunakan. So treponema pallidum particle agglutination or TPPA is the most common test being used untuk dalam group treponema test ya, menggantikan treponema pallidum heme agglutination. So sekarang ni I think most hospital pun pakai particle agglutination. Yang ni kita guna gel particle, yang ni kita pakai red blood cells. So dia ada isu juga lah. And TPPA are supposed to be is more sensitive than TPHA. That's why we are moving from TPPA dari TPHA kepada TPPA. Okay. Another test yang sekarang ni kita nak wawarkan adalah penggunaan rapid test. Sekarang ni yang telah dimasukkan dalam flow antenatal screening yang saya akan bincang sekejap lagi, dan saya rasa yesterday pun Dr. Nik Masrina dah tunjuk dah the flow chart. Next adalah enzyme immunoassay ya. Okay, enzyme yang saya akan bincang sekejap lagi. Satu lagi test yang ada yang digunakan adalah fluorescence treponema antibody adsorb test. Cuma yang ni memang not available in KKM lab ya. So saya akan bincang lebih kepada TPPA, rapid test dan enzyme immunoassay. So untuk treponema pallidum particle agglutination, ia adalah satu method di mana agglutination of gel particles sensitized with treponema pallidum antigens by antibodies found in the patient serum. Selalunya dia ambil masa dalam 3 jam, dan usually memang kita akan buat done in batches, and LT18 varies ya. Ada hospital akan buat one day dalam masa 1 hari, ada yang buat 3 kali seminggu, dan ada yang buat seminggu sekali. So ini yang kita nampaklah kelemahan-kelemahan yang menyebabkan lambat diagnosis ya. Sakit terpaksa datang semula ya. Test ni cuma ada di state and major specialist hospital. Sebab even in Kedah dulu kita, bila dia tak berapa cost efektif. Kalau district hospital yang nak buat sekali seminggu atau ada dapat case 2 minggu sekali, is not cost effective ya. Sebab setiap kali kita run kita perlu ada control. Jadi kalau lama banyak yang expired. That's why due to that yang kita kadang buat the test in batches. So this is treponema particle agglutination ya. So kalau negatif maknanya kita panggil ini pattern ya. The clumps tu dia duduk dekat bottom of the valve. Okay. Negatif. Yang ni dia akan yang ni dia akan menjadi ring ya. Dia akan jadi ring. So this is the control yang kita perlu buat. And actually 10:45 hingga 12:45. So it takes 2 hours. Ini untuk selepas buat dan dibaca. Jadi termasuk persiapan untuk present itu saya kata dia akan mengambil masa selama 3 jam. Jadi susah kalau kita nak buat satu-satu saja ya, in terms of kita kena buat control. So that's why ini adalah satu maybe kita nampak kelemahan yang menyebabkan kelewatan dalam keputusan ujian. Okay, third tadi nombor 1. Kemudian saya nak cakap mengenai treponema immunoassay. Immunoassay ni kalau you all familiar seperti ELISA ya, enzyme immunoassay, chemiluminescence assay ataupun immunoblot. Sekarang ni most of makma-makma yang banyak workload ya, mungkin dari segi selalunya dulu pernah macam kalau di blood bank yang terpaksa screen untuk syphilis banyak, they will go for immunoassay ya, sebab is automated, it will reduce labor and turnaround time. Dan di hospital kita, hospital Sungai Buloh actually menggunakan automated immunoassay ya. Bila kita menggunakan automated immunoassay, dia algoritma tu dah bertukar. Kita tak guna algoritma yang biasa kita guna. Maknanya kita test non-treponema dulu followed by treponema. Tapi dalam case untuk ujian ni kita start with treponema test and followed by non-treponema test. Okay. So this reverse screen, kita panggil reverse screening algorithm ya. Semalam I think ada juga pertanyaan if kalau treponema test positif, adakah kita kata itu false positive. So if treponema test positive, non-treponema negative, it should be repeated in a different treponema test to confirm the results of the initial test ya. Maknanya macam di hospital, saya bagi contoh lah di hospital Sungai Buloh, dia run dulu. Kalau negatif, dia run EIA, sekiranya positif tetapi lepas tu buat PR negatif, they will repeat the test with TPPA. Ya? Dia akan ni. Jadi saya rasa sama juga nanti yang flow yang kita akan gunakan untuk rapid RDT. If second treponema test is positive, it is consistent with recent or prior syphilis infection. If second treponema is negative, maknanya kalau kita repeat TPPA negatif juga, it may be a biological false positive, tapi perlu diulang ya. Sekiranya we have a suspicious, repeat if necessary for rise in titer ya, tengok titer and also TPPA seroconversion. Okay. Next, we move to rapid syphilis test ya. Yang ni yang kita nak dalam tajuk saya actually penggunaan rapid syphilis test in antenatal screening. So actually WHO dah keluarkan publication ya, the use of rapid syphilis test ni untuk dalam antenatal. Seperti point of care testing lain lah, seperti RDT yang lain, RTK yang lain, it is a simple point of care. Boleh buat bedside dan boleh menggunakan card or strip. Selalunya the methodology is immunochromatography macam UPT ya, and it is easy to perform, tak perlu training yang banyak ya, minimal training. No equipment needed, tak perlu mikroskop, tak perlu heater ya, tak perlu centrifuge untuk, because dia boleh menggunakan use fingerprint blood sahaja and the results within 30 minutes. Dan selain daripada syphilis test kit saja, sebenarnya dia dah ada juga dual test kit which is available, HIV syphilis. So maybe lepas ni kita pun akan take up lah, sebab kita nak screen untuk HIV, kita nak screen untuk syphilis, maybe using the dual test kit is better. Cuma in terms of cost ya, because yang ni lagi mahal. Tapi saya rasa makin lama selalunya harga dia makin murah. So this is another option that we might think of untuk mempercepatkan lagi all the tests, all the results. And the sensitivity ranges from 85% to 98%, and specificity ranges from 93% to 98%. Ini adalah daripada WHO yang telah melakukan evaluation. Okay. Untuk screening, we need to have a kit which is very good in sensitivity. Dan untuk kita lihat untuk kit mana yang boleh digunakan, we can see dalam MDA website. Semalam saya dah search, saya rasa lebih daripada 5 approved kits dalam website MDA, cuma pagi ni saya tak masuk. Next, kita kata macam mana kita nak choose the RDT yang kita nak gunakan dalam ni. Kita kena tengok performance dia. We have to look at the test performance, the sensitivity, the specificity, ease of use, senang ke nak digunakan, tak perlu banyak training, conditions of use, conditions of storage, tambah-tambah di tempat kita yang memang panas. So selalunya rapid test kit dia boleh dalam keadaan between 4 to 30 degrees and up to 40 degrees. Cuma kita kena pastikanlah kalau tempat tu, sebab tu even store pun kalau kita ikut MSKH, you kena ada temperature, tengok temperature. Sebab kalau temperature tu over, we need to look at the quality of the test. And if possible, choose a long shelf life. I think some of the negeri pernah buat penilaian. So before semalam ada pertanyaan sama ada IMR pernah buat evaluation ke tidak on RDT. Saya telah berhubung dengan Dr. Haida. So far dia kata tak ada. Sebab untuk bacteriology saya rasa dia tak memerlukan evaluation untuk approved by MDA. Tetapi MDA akan go tengok the test kit, performance dan sebagainya. Jadi yang mana-mana yang boleh diluluskan kita beli. Tapi saya cadangkan supaya before you use, buat dulu evaluation at your own place. Dan saya rasa Johor dah pernah buat evaluation. Sama juga di Hospital Sultan Bahiyah, kami dah pernah buat evaluation some of the kits. Cuma sebab itulah kadang-kadang evaluation tu tak sempat nak tulis report. And bagi siapa-siapa yang mana-mana negeri pegawai-pegawai in charge HIV yang tahu negeri mana yang dah buat ni, maybe we can share the evaluation supaya kita tahu mana test yang bagus yang boleh kita beli untuk digunakan. Sebab I think kita tak ada central evaluation. So it must be done at the local level. Mungkin saya rasa dah ada plan sebenarnya untuk membeli kit ni di peringkat nasional. So kalau di peringkat nasional akan buat evaluation lah. Tapi ada yang mungkin dekat selain daripada test yang perlu digunakan untuk yang telah decide by KKM tu, yang kita nak buat sendiri, if you want to buy on your own, you have to look at this criteria sebelum kita memilih RDT mana yang kita nak guna pakai. Okay, yesterday saya rasa Dr. Wan Mazlina telah tunjukkan the interpretation of the syphilis test. Tadi pun Dr. Chu juga ada tunjuk. Selain daripada serology, what are other methods? Yang ni tadi Dr. Bun dan Dr. Chu pun dah mention. Cuma saya yang ni sebab in dark field microscopy is one of the tests untuk kita diagnose syphilis. Selalunya bila patients ada signs lah, ada lesions, So dark field microscopy detects Treponema pallidum based on morphology and motility. Tapi kalau tanya hospital sekarang, most of us tak buat lah. Ya, bila sebab I think we need skilled personnel. Bila nak maintain competency, you need to look at many cases baru you boleh kenal. So it's quite difficult lah. It's quite difficult sekarang untuk nak cari orang yang berpengalaman yang boleh melakukan dark field microscopy. And the other things yang coming in mana-mana penyakit pun is the nucleic acid testing, PCR. Ya. Ia boleh digunakan untuk primary syphilis in lesions, tapi dia tak boleh test from blood ataupun serum. Maknanya kena ada skin lesions or syphilis lesions, then kita boleh ambil dan gunakan dan hantar untuk nucleic acid testing. But I think for now it's not being offered lagi lah di mana-mana facility PKM ya. Okay, next, okay, saya dah habis bercakap mengenai test-test yang dijalankan untuk syphilis ya. Sekarang saya masuk kepada laboratory investigation of syphilis in antenatal. Okay, yang ni carta ahli ni dah ditunjukkan semalam ya, di mana bila ibu mengandung hadir untuk pemeriksaan antenatal, kena ambil darah untuk RPR, VDRL ya, dan dihantar ke mama. Ini adalah lab base ya, lab base. Dan sekiranya ujian RPR VDL tidak reaktif tapi ibu berisiko tinggi, we need to repeat at 28 to 32 weeks. Okay. This is strategi saringan standard berasaskan mak-mak. So tadi bila saya kata kalau RPR pun ada yang ambil 2-3 hari, lepas tu TPPA pula mengambil masa seminggu. So there is a delay there. Yeah? There is delay in getting the diagnosis. Yeah? So jadi Jawatan Kuasa Penerangan Kebangsaan bagi Eliminasi Jangkitan HIV dan Syphilis dari ibu ke anak telah mengenal pasti kelemahan-kelemahan yang saya sebut tadi lah ya. Jadi tidak mengambil sampel, banyak fasiliti kesihatan tidak mengambil sampel untuk ujian pemeriksaan syphilis pada hari yang sama semasa ujian saringan syphilis dapati reaktif ya. Ialah kalau dia dah buat petang, patient dah balik ataupun test tu dibuat ada esoknya ya. Jadi kadang tak ambil, tak buat tu, jadi terpaksa datang semula untuk ambil darah ataupun bila dah ambil darah kadang-kadang even in the same state pun untuk menghantar spesimen daripada satu tempat mengambil masa dan selepas tu juga untuk pengembalian result. Jadi overall the turnaround time is prolonged. Dan jadi kita nak tengok role of RDT in antenatal screening. Jadi selepas kita dah dapat kelemahan tu, kita dah tahu kelemahan tu kat mana. Jadi penambahbaikan terhadap garis panduan itu kita menggunakan kit ujian pantas, rapid testing adalah digalakkan agar ujian pekesanan rawatan dapat dilakukan pada hari yang sama. Okay. Ya, supaya kita tak miss the patients lah, sebab kadang patients tak balik semula. So ini I hope you all can see ya. Semalam pun nanti telah dini RDT screening for following cases or situations lah, hard to reach population. For example, orang asli remote areas di Sabah Sarawak, klinik kesihatan ataupun KIA yang tak ada lab facilities ya, sebab ada lagi klinik-klinik kesihatan kecil yang tak ada laboratory facilities to perform RPR and VDRL test ya. Sebab RPR dia pun memerlukan kena lab base ya, perlu lab base, tak boleh buat SPCT. Late bookers at third trimester and high risk members. Jadi high risk mothers. So dalam high risk mothers ni termasuklah unmarried pregnant ladies, sex worker, history of HIV, history of STI, history of multiple sexual partner, history of abortion and stillbirth, rape case, history of alcohol, drug consumption, dan having sexual partners with syphilis. Jadi bila mereka datang, darah akan diambil untuk RPR dan juga rapid diagnostic test ya. Jadi bila rapid diagnostic test dilakukan as a POCT, jadi dengan tu FMS ataupun medical officer dapat initiate treatment on the same day ya, tak perlu tunggu. So I will not go on the management lah ya. So jadi inilah tujuan kita sebenarnya untuk memasukkan RDT test ni dalam syphilis screening for pregnant ladies untuk memastikan tiada berlaku mother to child transmission of syphilis ya. Okey, saya akan sentuh sikit regarding laboratory diagnosis of congenital syphilis. Dr. Chu pun dah ada sebut tadi sebab ada isu yang saya nak bangkitkan sikit. Okay, laboratory diagnosis of congenital syphilis can be difficult sebab the immunoglobulin, the antibodies can be transferred through the placenta to the fetus. Jadi bila kita dapat dekat newborn tu, kita tak tahu sama ada it can be from the mother. Okay. Jadi antara kelemahan yang satu lagi yang dikenal pasti tadi adalah kegagalan memperolehi titer ujian RPR ibu sejurus lepas kelahiran telah menyukarkan perbandingan titer ibu dan bayi yang perlu dibuat. Tadi kita kata dia kena ada 4 kali ganda ya, baru between RPR bayi dan ibu untuk mengatakan is the diagnosis of syphilis, congenital syphilis. Jadi bila dalam mesyuarat mobility sebagainya, kadang-kadang benda ni tak ada, ya, tak diambil sekali. Jadi susah untuk kita nak buat diagnosis, ya, susah untuk nak buat diagnosis. Jadi untuk laboratory diagnosis, you have to take mother's RPA titers at delivery and neonatal RPR titers at the same time and conducted by the same laboratory. Yang ni pun telah ditekankan tadi. Do not take blood from umbilical cord blood because it can be contaminated with maternal blood and yield of false positive results. And water jelly yang ada dalam umbilical cord can yield of false negative results. So ini yang saya nak sentuh sikit mengenai laboratory diagnosis sebab yang tadi Dr. Chu dah mention lah, dah bagi tahu the diagnosis of congenital syphilis, you have to look at clinical and treatment. Satu lagi, the last yang saya nak sentuh adalah assuring quality in laboratory testing. Macam Dr. Rozaina ni pun dah mention ya, whatever this in, even dalam WHO pun dia memang minta berapa banyak kita punya lab yang involved in EQA dan sebagainya. Ya, bila kita bercakap pasal quality control and test kit, we have internal quality control, we have external quality control. Yang saya rasa tak banyak lagi yang laboratory yang menjalankan ujian untuk pendiagnosan syphilis tidak terlibat. Ya. Tapi saya rasa pada tahun lepas rasa MKAK telah meningkatkan bilangan EQA, pusat-pusat EQA. Okay. And proficiency of users. Kena perlu training, and kena ada SOP yang jelas bagaimana test tu perlu dilakukan. Ya. Bukan setakat test tu dilakukan, daripada penerimaan test kit tu, di mana nak simpan, macam mana kita nak monitor dan sebagainya. Ya. Okay, I've come to the summary. Serology remains the mainstay of laboratory diagnosis in syphilis, and it requires both non-treponemal and treponemal tests. And positive non-treponemal tests need to be confirmed with treponemal tests. And now there is increased use of reverse algorithm testing with automation, and use of rapid diagnostic tests allow immediate treatment and prevent maternal to child transmission of syphilis. So thank you very much for your attention.
Okay, terima kasih Dr. Noraini for your presentation. So kita boleh jawab soalan sekarang Dr. Noraini, boleh ke?
Ya.
Okay, so kita ada dua soalan sekarang ni. Soalan pertama daripada Bunga Budul. Kalau ibu itu dibuat rapid test pada 28 minggu POA untuk second screening dan didapati reaktif, perlukah repeat test lagi? Doktor, dengar tak?
Tak, saya punya
Oh, yang start sharing doktor tengok kat atas tu ada macam orange kan?
aha,
Bawa mouse ke situ, ke panel orange tu,
aha,
nanti dia keluar stop sharing.
stop sharing. Okay.
Ada panel orange, yes. So doktor pergi tengok dekat chat box, dekat belah kanan bawah tu, klik dekat macam
Kalau ibu tu,
soalan pertama, question 1.
kalau ibu tu dibuat rapid test pada 28 minggu POA untuk second screening dan didapati reaktif, perlukah repeat rapid test lagi? Dalam flow tu, bila kita test rapid test, kita akan follow management untuk positive cases. Saya rasa ini dah akan jadi, kita tak repeat lah, kita akan buat flow yang kepada RPR dan juga TPPA. I think dalam channel saya nak tunjuk yang tadi. Sekejap ya.
Okay, doktor.
Repeat test at 28 weeks. Bila positif, ya, bila positif, dia akan balik semula kepada yang management of positive, management of test positive TPPA lah, TPPA. And we have to do the RPR untuk tengok dia punya title. Maybe maybe kalau in terms of management, any disadvantages of using rapid test? Soalan kedua, any disadvantages of using rapid test? Lepas tu ada apa lagi? Saya nampak sekerat, Dr. Izzah, tolong bacakan.
Saya rasa itu je soalan dia. Apakah disadvantages of using rapid test?
Lepas tu dia dapat akan dilakukan RPR, tak perlu RPT.
Yang tu jawapan daripada orang lain. Daripada Dr.
Okay.
Gita actually.
Okay.
Soalan question tu, ini disadvantages of using rapid test je. Itu soalan dia.
Dia bila nak kata kalau disadvantages tu, sekarang ni kita kena make sure the rapid test tu memang a very good quality, sebab kita takut kalau kita tak dapat yang very very good sensitivity, ya, sebab kita gunakan ni, kita takut kita miss the case. Ya. So kalau you still ada suspect in high cases, you still need to repeat the test lah dengan standard method.
Okay, thank you Dr. Noraini. Saya rasa itu je soalan-soalan yang beri. Okay, terima kasih Dr. Noraini atas komitmen dan kerjasama yang diberikan sepanjang webinar ni lah. Maaf kerana ni lah asyik mengganggu doktor, tanya slide semua kan. Okay, terima kasih banyak Dr. Noraini ya.
Sama-sama Dr. Izzah.
Baik. Okay, now we are I think we already have concluded our 2-day webinar, and it seems that all of us today, we already finished our final speaker already. And regarding our webinar on strengthening prevention of mother-to-child transmission, PMTCT, of HIV and syphilis program in Malaysia, updates on PMTCT guidelines 2021. We at the HIV, STI and Hepatitis C sector of Disease Control Division, Ministry of Health, would like to apologize for any shortfalls or any hiccups throughout the webinar. We would also want to extend our gratitude to the National Institute of Health, NIH, for co-organizing the webinar with us together. And many have been asking about the presentation slide. We will email the presentation slides to everyone after we have obtained permission by all of the speakers. Number 2, e-certificates will be given to everyone through email. Number 3, kindly be reminded to register your attendance in order for us to email the presentation slides and for us to email your e-certificates. And we will display the QR code for CPD claim. The QR code is meant for medical doctors working in the government sector. As for other sectors, we will communicate to all of you through email. Okay. We will now share the QR code now, and it will be displayed for around probably for around 20 minutes. However, you can still look at the QR code afterwards by playing back the YouTube video. One more additional information, you can subscribe the NIH YouTube channel that you are using at the moment for more information, not only PMTCT, but other more informative information that you can learn from. With that, thank you very much and hope you all have a nice day. Thank you very much.
Sometimes there's no one else who loves me like you used to. Sometimes we're not ourselves. There's no one I can turn to. And I know all the feelings that we shared are in the past. And I know your relationships are never meant to last. And I'll take some time, but I'll be alright. Moving on, moving on. I know times are good, but I've had enough. Moving on, moving on, moving on. Sometimes there's someone else who loves me like you used to. Sometimes we're not ourselves. There's no one